Studying to go traveling across the nation. All right, you should be good at all of that. Then I decided
Okay, so you should sit to share just be participants in your track.
an 8-year-old.
And you can go ahead and start with
a 19-year-old. Yeah, she's an exercise instructor. I was like, okay, I'm done.
Yep, there you go.
Yeah.
Darling, so get some log.
Yeah, so she loves the first one. There's a book, which is good. Yeah,
Okay.
so there's like that, and now I
Wherever you
stay
take
in long
Oh,
too
we can
much.
mark it.
Dementia, zero educator. I make hair goes on the side. Which one? You know, you always have to have like 5 sides. Yeah. Kids are all excited to get to stay in camper in the parking lot this weekend. Oh, yeah. I mean, I'm probably gonna do so we're in the green line. I apologize in advance. Mom has been out a lot.
See our strong.
Yeah, just one of Yeah. I like it. Well, I was in first year, but I kind of had a little problem.
I know, I just.
I
thought it.
My lunch is in your office.
I know, like triage, I can like but then like oh world, yeah, oh well. I don't know, like I can't. I don't know if they're babies. I don't know if they're babies.
All right, guys, welcome. I'm the first presenter today. My name is Kaylee Nolan. It's good to see everybody. Go ahead and share my screen for those of you on Zoom. Okay, guys. So again, my name is Kaylee Nolan. I'm going to be talking about visual impairments and considerations for us in OT. Just a little bit of background about myself. I practiced in acute care with a lot of focus on the neurology unit, so working with a lot of individuals with neurological impairments. I also worked at Chestnut Ridge where I did mental health. And I also recently, as of just a year ago this month, passed the specialty certification in low vision through AOTA. So those are the SCLV at the end of my name. So that's exciting. I got to learn more about that just to see what I could help my patients with. So this is just the slide just talking about an overview of what we're going to be talking about today. So just wanted to give you guys an idea of some of the common neuro-based and traumatic visual impairments, discuss some implications for us and related to occupational performance and how we address this with our patients, as well as some intervention strategies within our scope of practice. So I wanted to first touch on the idea of acquired brain injury. And acquired brain injury can be anything from a traumatic brain injury to a stroke, to a tumor, or anything that is acquired or comes on when you have an injury. So when we have this kind of injury, we do see that there are changes in several visual functions. So mainly 4, and that is your visual field, which is the central as well as the peripheral field that you can view objects in. We also see changes in visual acuity and focusing, so your eye's ability to focus and provide detail of information.
You're good? Great.
Yeah, thanks. We're good. Also see issues with ocular motor control, or your eye's ability to coordinate and work together, as well as visual attention rather. So being able to take in information, sort of distinguish it from the things that aren't as important and really focus in on that. And when we see these deficits, it can range from mild to severe. So a lot of individuals like with traumatic brain injury, they might have some mild visual deficits alongside some cognitive and motor components, because the brain and the way it works is that from the front of our brain all the way to the back, it has various interconnected pathways, and we can see damage in any of those pathways that aren't always structural, so not always shown on imaging. And that's where we need to always be looking at visual impairment. As you all know, in working with clients, and those of you as students who will be working with clients, one of our considerations is that the picture of the client is very complex. So we understand that they have motor components, language components, psychological components that we all need to consider, along with visual and other sensory components. Often too, a client can present as an ambiguous picture. So we might have clients that maybe present with impairment that look a little more motor, a little bit more cognitive, but we know that vision and visual processing is a big part of the way our brain is working and the way it functions. So we know that vision actually serves or promotes our ability to carry out cognitive and motor functions. Within practice, we too know that visual impairment often slowly reveals itself. So this is where early on, it's really key to use your observations. So picking up on patterns that your client may be doing. So it could be anything from, I'm noticing they're really just inattentive to that left side. I really need to get them tracking or turning their head to engage in that side. Or, hey, talking with the PT when they were mobilizing, I noticed that, they may frequently run into objects on this side. So we want to consider and use our observations to make clinical decisions. We also know too that visual impairment often persists after other impairments have resolved. And this is primarily true for individuals with traumatic brain injuries. So we see a lot of recovery. Obviously, some of it can be very soon and very fast. Other times it does persist, and vision is one of those things that we do try to address as early as possible, but it's often a condition that is going to have lasting impact. So when we're looking at our role in occupational therapy, we know that our goal is just to assist the clients to engage and to support their health and participation. So we're not about solely focusing on how to improve their visual processing or how to fix them, but we're helping them to compensate, helping them to adapt, helping them to participate, because with visual impairment, it's easy to kind of start getting into habits where you drop occupations. You don't want to participate anymore. And we can prevent that by giving them strategies to help support their participation. This visual that I just included here just represents a few things. So here on the left side, this just represents the hierarchy of visual functioning. So here on the bottom, as you all can see, we have ocular motor control, visual fields, and visual acuity. Those are the foundations for us to be able to use our vision to scan, to have memory, to adapt through the use of our vision. So it works in a hierarchy here up to the top. We too know that the eye isn't the primary means of collecting information. It's actually our brain. So our brain is the one seeing, not necessarily our eyes. But I also included a visual here on the right that shows just the structures of the eye, because we're going to be talking about some of the deficits here in a moment where we might have a disruption in the cornea, which is there on the front of your eye, and then also the lens there in the middle, that big round egg looking piece, and then in the back of the eye with the retina that helps to process and take in information and send those signals to the brain. So just wanted you guys to have a visual of what those structures are. So now we're going to move into talking about some common injuries that you might see in patients with both traumatic and neurological visual impairment. And one of the first ones I wanted to highlight was this orbital blowout fracture. So oftentimes after a traumatic brain injury or even just a general traumatic injury, you can have blunt force to the bones of your eye and the eye socket, and it completely shatters. But this causes shearing in a lot of those extraocular muscles. So we can see a lot of issues with swelling, which causes trouble with acuity and not being able to see things very clearly. It also can create a lot of pain and stress for our individuals who have this. So it's something to keep in mind if you do encounter a client with this. This can be in acute care, this can be an outpatient, it can be in any kind of setting. that you may want to just be aware of what kinds of issues this is causing your client. 2, we have the corneal scarring, which is where the middle layer of the cornea gets penetrated by debris or shrapnel, and it creates this sort of scratchiness on the eye surface, and that produces blurry vision. So again, more acuity, it causes issues with being able to detect detail of visual objects. 2, the next slide doesn't have a picture, but if you see that the center of this person's eye is sort of cloudy, their lens has also been impacted, and that is where you want to consider the traumatic cataract, and that is where you have blunt trauma to the eye again. This is a leading cause of monocular or single eye blindness, but basically the lens is helping to shape and keep the eye's shape intact, and over time and as age progresses, you often get yellowing and balling up of the lens. But if it's traumatic injury, it is influential in affecting visual acuity. So again, more of the ability for the eyes to focus, as well as causing issues with glare and being really light sensitive. Here we have a vitreous hemorrhage. And the vitreous is the back portion of the eye that's connected to the retina, but it basically is like a fluid-filled sac that helps to maintain the shape of the eye. But it can create a lot of issues when it has been hemorrhaged and it gets blood filling into that space. But the good thing is that our brains and our bodies are amazing, and it does reabsorb that blood. But while this is occurring, or when this hemorrhage occurs, it creates fluctuating vision. So the person can have a lot of disturbance. Usually it's when they move their head. So obviously most of the things we do, we move our head. So that can create a lot of issues. And typically individuals experiencing this see like floaters or blobs moving in their vision. It can also create some scariness because you're like, oh, like what is that? Or maybe you're seeing things that you weren't really, or not really there. So it can be kind of a scary diagnosis if you get a vitreous hemorrhage. But one of the worst or the scariest traumatic injuries is that of a retinal detachment. And this is, I have a picture of both a healthy eye there on the left and a retinal detachment depicted on the right. And right there's the retina where it just separated from the eye wall. And this creates a lot of issue with like you see flashes of light. It's a very emergent situation. So typically when you see clients, I usually tell them, like, be aware of what your vision is doing. If you notice any changes like bright flashes of light or something that immediate, it's an emergent situation and you need to get to a doctor immediately. But with retinal detachment, it's usually kind of painless. So the patient may not really know that it's happening, but then they realize over time that, hey, it has detached, I'm seeing this flashing light, and then when it detaches from the retina, which is what helps to facilitate the signals to the brain, we're losing pretty much all of our vision. So it can create a major low vision impairment. Here I just highlighted a central retinal artery occlusion. This is basically called a stroke of the eye. And a lot of individuals who experience this have chronic conditions like diabetes or high blood pressure, where the plaque builds up in their arteries and it creates a vascular disruption or an arterial disruption in their brain. So usually with this, unfortunately, the vision isn't always going to return back to its previous state. So this is a big education point for clients. And when I was in acute care, I would see individuals with this, and I had to talk to them, about how this is going to impact driving, how this is going to impact their just general carrying out IADLs like finances and caring for someone else if they do that. But generally full recovery of this is limited. So we do, again, need to address that long-term. This one is similar, but it's a vein occlusion. And this is just where the main branch of the retinal vein has an occlusion. And we see this in a wide variety of causes, but it causes visual changes such as diminished acuity or decreased focusing, photophobia, which is light sensitivity, eye pain, and redness. These are just some examples of how traumatic injuries impact occupational performance. So I feel like we all can think about some ideas and some ways that it does impact it, but these are three primary ones that I wanted to include for you guys, and that it can lead to a decreased ability to engage in activities of daily living, which is hence why OT has a big role. It does cause increased pain and discomfort. So if we have an individual with a visual impairment, we definitely want to help them minimize the stress and the pain that it does cause. So we might need to collaborate with a physician or an optometrist, or maybe some other options we can give them to help with pain and discomfort. We also may need to talk about how we structure our day with certain occupations. So maybe doing things when we're having least amount of pain, or not engaging in activity that maybe puts more force into the front of the face where our eyes are having more pressure and issues with that. And also traumatic injuries can lead to an increased risk of falls. So we see a lot of changes in depth perception. So going up and down stairs, navigating in the environment can be very challenging. We're now going to move into talking about some specific neurological visual impairments. And one of the ones I wanted to mention was that of optic neuritis. And this is often associated with individuals with multiple sclerosis. And it's basically where the optic nerve slowly demyelinates, or the coverings on their nerve slowly diminish. And this can create a lot of changes in visual function. So they can have a lot of eye pain, acuity issues, decreased ability to detect contrast, so being able to distinguish an item from its background. Also too, a lot of individuals can experience a decreased color vision. So this is where our central portion of our vision, that's where we get our detection of color and detail, whereas our periphery gives us the idea of movement and that kind of stuff. So this is where the central part would be affected. And like MS and like the progression of the diagnosis, their visual component too can have reoccurrent attacks where they might have exacerbations where it gets worse and then they kind of recover. But with the vision too, this slowly still progresses and gets worse over time. So something to educate clients on as well. This slide just represents if you have an individual with occipital lobe damage. This is usually in more severe cases. So if you have a severe traumatic brain injury, multiple strokes, but it can create a wide variety of issues in your vision. And a lot of that too is where they're just seeing dark, kind of like a black curtain, or just not even really able to detect detail in their environment, as well as creating phantom vision episodes. So it could be pretty severe in their it's like a hallucination, but really it's called phantom vision. So that is a common disruption if you have an occipital lobe injury. Here is accommodative dysfunction. And this is one of the most common ocular motor issues in both adults and children. And this is highly prevalent if you have an individual with a TBI. I mean, kids, sometimes it can be congenital or they have it from birth. But it is common for individuals with accommodative dysfunction, or where they have difficulty focusing and being able to, typically it's more in convergence, which your eyes move inward. So that's really important for near tasks like reading and writing and doing like your bill paying. But it's also important for moving your eyes out, or divergence. So we know that our eyes can't go way out here and coordinate together, but as we move objects further away, and if we're observing something at a distance, my eyes do have to move out together in order to see that image clearly. I also wanted to mention nystagmus. Nystagmus is where we have a rhythmical beating of the eyes. I feel like most of us are pretty familiar with that. But because nystagmus, so the individual, even though their eyes are beating and moving like that, they still perceive the image as stationary. So that can create a lot of stress and reduced acuity. So still a lot of blurriness, a lot of stress and fatigue for that individual, because they're working extra hard to trying to focus their attention on that image without their gaze being stable. This one is also, oh, I went backwards. Whoops. There we go. Occupational performance with ocular motor issues. We do slow visual processing. So again, it takes more time to decipher kind of what the information is you're taking in. It creates stress, very, very fatiguing. So this is where we educate our clients to really kind of do those harder tasks when you have the most energy, the most like right when you wake up in the morning, that may be the best time to do certain activities. And obviously, again, it impacts a lot of daily activities. One of the most common neurological impairments that we know and understand is usually a visual field cut or a visual field deficit. And this is one of the most common visual impairments following traumatic brain injury. When we look at this occurring in individuals with a stroke, we often see this if they have an infarct or a lesion in the right hemisphere of the brain, and the PCA or the MCA strokes, those are the ones that can create more of the visual field or visual field cuts. And again, I just included the central field and peripheral field and what kind of information those give you. I did want to point out here too, the eye, when we are trying to detect these field cuts, it is broken up into 4 pieces or 4 quadrants. So the upper 2, those are superior quadrants. Lower 2 are inferior. When we're looking at 2, the inside of the eye, so the one closest to the nose, that's the nasal portion. The outside or the periphery is more called the temporal. So when we're trying to decipher where it is, we could say it's superior nasal or inferior temporal, and that gives us an idea of where exactly that is located. This picture looks really complex, but I just wanted to give you a visual of these are this is the visual pathway in your brain. So you have where the information's coming in, the optic tracts and the optic nerves with the optic chiasm there where it crosses, because you take in information and then it goes contralateral. And depending on where the infarct is where you're going to see your deficit. So I just feel like that gives you a very nice visual. Now you'll see here in E that it adds like a little kind of round piece there in the middle. That is called macular sparing, and this is where the individual can have sparing of the macula, so their central vision and the information taken in is sort of intact still, but they're still having this great field cut. So that's a unique factor that if individuals do have their macula spared, they're going to have a little bit more usable or functional vision that we can use. Field deficits create a lot of changes in occupational performance. So we see a lot of behavioral changes, influencing quality of mobility. Individuals might be a little bit more cautious when they're moving, a little bit more intimidated. They don't really know or are oriented or detect space. So often individuals can maybe get lost. They're a little bit more not detecting where they are at in space. So that can be a challenge. If you do have a field cut within your central portion of your vision, you're going to have difficulty with reading and writing, because that's a big ABL or a big task that we do for central vision. We can also see issues with eye-hand coordination. So something like we are working in the kitchen and wanting to pour ourselves a glass of water from a pitcher, that's going to create a lot of issues if we have a visual field deficit. Something too, and I'll show the second year students in lab, but there's like an adaptive equipment out there that it's a little piece that you stick on a glass and it whistles as you get close to the top. So it helps give that auditory cue, hey, you're getting close to the top, don't overfill it. So I think that's a cool thing that has been adapted. I wanted to point out on this slide too, one of the most common or one of the most difficult things to distinguish clinically when we're looking at vision from a neurological standpoint, and that's homonymous hemianopsia or HH and visual or hemi-inattention and neglect. So something I wanted to point out here is that homonymous hemianopsia is an actual physical loss of the visual field. So that's that first picture, or that top picture for you guys, where that half of each eye is gone. But with homonymous hemianopsia, the client is still and should be able to be engage in organized search patterns, so they're still going to go from left to right, be very organized and sequential in their choices. They're going to be able to maintain attention, and they're going to be able to respond to cueing. So that's a really big thing to consider there. Now, if the individual you're working with has inattention or neglect, and I include them both together because neglect is a more severe form of inattention, but this is very common after a right hemisphere stroke. But individuals are often not oriented, not only visually, but also multisensory. So they're not going to have awareness of their limbs, or even sometimes detect, like their brain does not even know maybe the left side even exists anymore. And this creates disorganized and random search patterns. So you might see that your client just goes to the middle and then darts back, or they might briefly be able to scan over here, but they can't sustain their attention to that neglected side. They also have difficulty responding to cueing. So that's where it can help you distinguish maybe which one your client has, and can help you decide whether to screen further for a homonymous hemianopsia or whether it's a more multisensory issue. This is just a slide talking about the occupational performance issues with visual field deficits. So the main things is that it creates gaps in what we're seeing. So we're not being sufficient in our information, and the brain is all about efficiency. So when we're not taking in information appropriately, it's going to adapt and create new patterns and predictions, and that can throw us off and be very stressful because we're not fully seeing what's going on in our environment. Two, I just wanted to highlight some performance issues with inattention and neglect. So often individuals can have difficulty locating items because of their spatial bias, which is basically you're biasing away from the unaffected side, or you might be overly attentive and can't disengage from the intact side. They also might have difficulty completing certain tasks or sustaining their attention, or even dividing and shifting attention. So this is where even like ambulation or functional mobility and talking, that could be very difficult for someone. Or if you have a client who's in a wheelchair, like my mother-in-law, who is pulled up to her table at her facility, and she's expected to eat with left neglect or left inattention and associate with her people around the table, it's going to create a lot of issue for her. And I use that as an example just to sort of give you that visual, but we're going to notice a lot of difficulty in working memory and sustained attention. So if your client is having issues in those areas, we might need to look at potential for inattention or neglect. Now for the fun part, and moving on to some interventions and how we can address these various diseases and visual impairments. So a lot of us, and what we're skilled at in OT, is we know how to do task analysis and environmental modification. So those are going to be some major areas where we can really focus on. We also want to encourage organizing and structuring the environment, so making it as simple for the client to engage as possible, because if we are in a disorganized environment, that's going to be an extra step that they have to overcome in order to participate. So if we can simplify and organize it in a way that's conducive to their participation, it's going to make a difference. So I did include some pictures just to give you some reference. So when you see the bolded, like they're both red, those are called pop-out effects, where you can see on the right-hand side, there's a patterned white tablecloth with a white plate. That was going to be very hard to distinguish. So they put a red placemat underneath where that allows the person to see the full plate as well as where their utensils are. I love this first picture too. They did a nice job at creating contrast between the stairs and the wall color, but they also here put a different color for the landing so the person could detect when the next step was going to be, as well as put a color on the railing, so that is an added safety component. These are examples of what not to do with your backgrounds. So as you can see, this is very patterned, very difficult to detect. So someone getting in that tub could have a really, really hard time transferring, as well as if we dropped an earring or a grooming item on the floor, it'd be pretty impossible to try to find it. And two, there with the sticky notes, there's just way too much information going on there. So if we could simplify that or back it off a little bit, it's nice that they use different colors of the Post-it notes, so that's a plus, but they could organize it a little bit better. Two, something that's commonly overlooked is lighting and how that contributes to our participation in daily activities. So if we can facilitate even illumination, so rooms like this where the whole room's lit up, we have even like corner lights on the cabinets that are enhancing our visibility. Some of the best lighting that you can get for your clients or to educate on in your facilities even is LED is the greatest one, but it can be a little bit expensive. So if you can't do LED, halogen is also a great one. But fluorescent, which is what is in most hospitals and places we work, are the worst. So when we think about that, that's even something to encourage your client to adapt with. So maybe we'll use filters to kind of wear glasses in order to eliminate the glare from that, or the glare from the light on the tile floors. Like I remember at the hospital, they would wax every morning, and then it was so terrible for patients to come out and mobilize in the hallway because it's just so stressing to them. So you want to consider both room or overall lighting as well as task lighting, where you could put a lamp or something where the person is actually engaging in the task. Contrast is also a big one. So we see that white or black on white is the best way, but a lot of adaptive equipment out there, like closed circuit televisions, which are really big, like monitors that intensely magnify things, you can have where you change the contrast and put like black words on a yellow screen, or you may have seen these on your accessibility features on your laptops. Those are excellent, like low cost things you can do with your clients. And we've talked about this already. Those are just a picture of glasses that you can use to reduce light sensitivity or glare. Usually the amber color or the orangish color is usually most preferred with clients, but it's a great way to allow the client to be portable. So they could take this with them and go out in any kind of environment while adjusting to the glare. Two here, one of the most common interventions that we hear about with neurological impairments with vision is to use occlusion, where you either have full occlusion where you cover the whole eye, or you have partial occlusion. Something unique that I learned from my additional schooling that I didn't realize before was that full occlusion or occluding the whole eye is really not very good for your clients. So it creates a lot of stress because you're taking away that whole vision. It also is covering their peripheral vision. So they're not going to be able to utilize that to mobilize. It throws them off balance. It's also very stressful, so they often have poor compliance with it. So in OT, I usually encourage trying to do partial occlusion first. So if we're talking about the quadrants of our eyes again, focusing more on blocking or occluding the nasal side or the inner portion to allow both peripheral fields of the eyes to continue working together. That's another important thing, is that we're still facilitating in partial occlusion for our eyes to work together, whereas if you fully occlude, you're taking away both of the eyes' ability to work together, which can create issues over time. And that's a big difference with kids. So in peds, we always say, do not do occlusion unless you speak specifically to the physician, because over time, if you implement this with a young child, they don't have the visual memories to go off. They don't have the skill and the experience. So they often can exhibit a lazy eye and have decreased use of their eye. We also use a lot of visual or occupation-based interventions for neurological impairment, and most of those are what we've talked about. But I did want to highlight here on this slide that modifying routines and roles are important. And this is basically just pacing the environment, pacing participation. So we might want to do short spurts of activity rather than full-blown engaging in busy times and busy activity, as well as doing things that are more stressful when they're more alert or more rested. And we want to promote a balance between activity and rest. And this is hard for all of us, but especially if you have a visual impairment, we do want to make sure that we're educating our clients on that part. These are just some interventions for mobility, and a lot of this we encourage with scanning. So working on head turning is a big one. Just trying to identify details in your environment. I often would do in acute care at the hospital scan courses where I'd walk out in the hallway and be like, okay, there's a sign over here on your left. Tell me what it says. What color is it? Okay, can you tell me who's standing there? How many people are out in the hallway? Those kinds of things can give you a lot of information in a short period of time when you're engaging them in that way. A lot of this too can be occupation based, so you can take them to a grocery store and have them looking at the different shelves and identifying objects, or seeing, okay, I want you to start at the top shelf where you are and tell me everything you see and then move to the next line, and seeing if they're actually engaging in that efficient search pattern if they have inattention, for example. Interventions for reading and writing, mainly education is key, but we can also implement some exercises where they do reading like familiar material, maybe in a larger print, and then maybe working towards decreasing the print slowly. Something I've done for my mother-in-law, I mentioned her as an example. She has severe inattention to the left, so I would put a highlighter on the left side of her page and say, go to the highlighter and then start reading the line. And she would always train herself and cue herself to go to the highlighter and read, because reading is a big occupation for her. This is just a list of additional interventions for writing. So again, more occupation-based, can write bills, can write a letter, write your grocery list, and just modifying the task with those things we've talked about with increasing illumination in the environment as well as maximizing contrast. Some interventions for inattention. We do want to modify the environment to facilitate attention. So something I would do in hospital, especially if I had like a lower level kind of patient, I'd get them sitting up on the edge of the bed. Maybe if, before COVID times, I would have their family members come. I'd be like, or if I would say, please bring them like a picture of their dog or their grandkids or something like really motivating, and like get them looking, okay, follow that picture, follow that person. Oh, if your wife is here, let's reach over to the left and give her a big hug. Like those kinds of things, integrating all those senses is huge. We can also use metacognitive approaches to sustain attention in that last bullet. And that's something where you encourage the client to think about it and process as before they do it, and then while they're doing it and after they do it. So if we take, for example, brushing your teeth, you can have a client decide to, okay, before I start, I'm going to do this, this, and this. I'm going to grab the toothbrush, put the paste on the brush, hold it underneath the water, and go forward. Then during the task, they talk themselves through those sequences. Then afterwards, they reflect on it and decide how that's going to be improved next time. So those are a lot of ways to work on grading or sustaining attention in that way. And these are just some visuals to work towards adapting, like reducing your stress with your visual processing or attention. So we've talked about how lighting is really poor there. This one, it has windows. So obviously we can't really change the fact that it has windows, but maybe we could add shades to it. Maybe we can add filters on the windows where maybe it doesn't have to be a shade, but like sort of like a plexiglass kind of thing that would sort of cover it a little bit better where it's not creating a disorganized hallway there. And then that last one just represents her illumination is not very good. So we could even enhance that there in her room as well as on the computer. We've talked about this too already, serial search. That's a really big, important one that you can implement. Something too I wanted to mention was sensory input. So these are, the first one there is a Fresnel lens, and a lot of individuals have found this useful. It can be a variety of uses for individuals with neurological or other visual impairments. So some of the lenses, they will offset the refraction. So when it comes into the eye, the person has to look to their inattentive sides and it slowly trains them to engage again. Or they have ones like the gentleman is wearing there in the second picture, where the lines on his glasses are refracting the light in different ways to where when he processes it and his brain takes in that information, it gives him an adequate picture of what he's seeing. This one I love. I just included this cute little man playing dominoes. It's just talking about how, engaging people in the things that they want to do, need to do. Again, the basis of what we are as OTs, right? We want to engage them in the things that are meaningful and that they enjoy. And that is my presentation. And I did include some time for questions and or contacting me if you have other questions. But thank you all very much. Yes.
I was wondering, so about the glasses, why are there different colors?
For the light, for the glare.
Yeah.
So some people, it's just sort of preference. So some people, depending on what environment they're in or what kind of lighting it is. So if the fluorescent is really harsh, some of those colors can kind of make it better or worse depending on which one you click or you choose. But typically it's a lot of just preference of what color you feel you get the most out of. Yeah. And I wanted to mention too, that brings up a good point that there's low vision clinics at the WVU Eye Institute. So there's some local places that support these kinds of things. This low vision clinic at the Eye Institute, they have two low vision therapists. They're not OTs, but they're trained in the equipment. So they offer training on the CCTVs and glasses and things that can help the client. We also have, through the West Virginia Department of Rehab Services, offers a visions program, which is all caps. It's if the client is returning to work, you can contact them and they'll go to their home and implement some modifications like little bump dots, which are little sensory components that you can put on the microwave or on your stove. So they do those kinds of things, which is really unique. I'm not sure, I think there's one in the southern part of the state, but depending on how severe the visual impairment is, that can lead to blindness where you might have to learn to mobilize with a cane. There's a lot of orientation and mobility specialists. I think, again, more in the southern part of the state that offer services to help with that too. So it's a growing area. Yeah, Kay.
You mentioned a lot of vision impairment come from TBI, but in acute care settings, since you only see them for 3 days, do you do much with vision?
Absolutely. So I do a lot in my evaluation. So when I would see a neurological patient, my evaluation was usually very extensive. So I'm looking at cognition, vision, motor, every component. And you're right, you do have that short period of time, but that's where I try to sort of talk about and educate a lot early on, because they may leave and I may not see them again. So I always try to take every opportunity, don't wait for the next therapist. Don't wait for them to go to outpatient to discuss these things. Kind of give them what you know and what you can help them with early on. And that too helps them process okay, this is how I can carry this out long-term and adapt to it and adjust, because there's a psychological adjustment too. Right? So you're dealing with this change, it's affecting multiple areas. But yeah, you're right, short term, and that's where great when we get to inpatient rehab, but some people don't have insurance. Some people can't, afford further services. Well, what can I do for you in this moment? And that's a lot what I would do in the hospitals, making sure that I tried to hit everything I could. Yeah.
Follow up.
Yeah.
So typically, do you make a referral to a specialist in vision, vision?
Yeah, so it depends. A lot of my friends, when I was over there, they would be like, hey, I want you to come see this patient because of my extra education. They would see what I think. But yeah, I've referred a lot of people to the low vision clinic at the Eye Institute. But like I said, They're not OTs, so they do look at things a little bit differently, but there's still some ways that they can help contribute. I've also had conversations with physicians like, hey, this is what I'm noticing. Can we talk about maybe doing a prism lens, or can you maybe explore this a little bit? But the thing about referral too is you don't want to refer too early. So a lot of this can sort of figure itself out, and you're gonna notice the biggest changes or the biggest recovery within 4 weeks. But after that, it's kind of deteriorates. So usually physicians prefer that if you do refer, you're gonna wait at least a month after the infarct or after the issue sets. Yeah, good questions. Yeah, Lauren.
If a patient reports like floaters,
Yeah.
is that always a sign of injury?
Really, like I get floaters when I transition from inside to outside a lot. So I'm like, hey, is it my mascara or am I having a retinal detachment? You know, so it's not as concerning. The bright flashing light, that's when you are like, okay, like that is an emergent, serious situation. But I wouldn't take floaters now if it's kind of a frequent thing, or it gets more frequent, or it's really impeding your function, where if you're like, man, these floaters just, they're getting in my way, I can't see to read, where it's impacting function, that's where we're gonna maybe want to start digging a little bit more to intervene.
Okay, thank you.
Sorry,
Either
another follow-up. Wait, so, well, because you mentioned in the vision center, like it was an OT, so the certification that you got, like what's OT's role in vision? Like what do you?
Yeah, so OT's role in vision is addressing the functional component. So with optometry, ophthalmology, they're the medical managers. They're focusing on acuity, they're focusing on impairment, whereas I'm focusing on how does that impairment impact you on a day-to-day basis. So I'm trying to modify their environment, the task. I'm trying to make adaptations to decrease stress that they're having, to help them do tasks a little bit easier. That's where OT's role comes in. And we do a lot of screening. So that's another big role of OT, is that we're not the diagnosers. We're not gonna just be like, hey, they have, you know, this vitreous hemorrhage that I'm picking up from my knowledge. You're gonna say, hey, I'm noticing these patterns, or I'm noticing these behaviors. I'm concerned that this might be an issue. And then you would maybe screen for it and educate and transition that information to a referral or to your other team members. Good question. Do you have one?
So when it comes to the clinical side and the billing side, because
Yeah.
that's a big component too.
Absolutely.
What do you notice as far as insurance accepting like CPT code? Like do you bill it more under the OT coding, or is there a vision coding that's accepted?
Yeah, that's a wonderful question. So I don't know much about the CPT codes like an outpatient. That's an area where I'd like to know a little bit more about, but in acute care, I would do it as part of my just general treatment and evaluation. But the big thing about like adaptive equipment, like CCTVs and those kinds of adaptive, a lot of it is out of pocket.
That's good.
And that is where the Lions Club, they collect a lot of equipment. So I would encourage clients to like, hey, call your local Lions Club, see if they have some extra glasses or a CCTV maybe you can have. Because yeah, that can be a big barrier to a lot of our clients. And I mentioned that too at the low vision clinic, because they show them all this wonderful stuff, but a CCTV, one of those ones where you can even have a working station where you write underneath of it, or you can cook and prepare a meal underneath that magnification. Those can be upwards of $3,000, which not everyone can afford. So I try to do like low tech, obviously, as my first go-to, but yeah, billing can be a big challenge for sure. Yeah, great questions. Bathroom break. Okay. Zoom, you guys can go to the bathroom too.
Yeah.
Oh, okay.
They're hidden. But I broke my mask.
Thank you. I just needed more information.
How did I get to you?
Sweet. I'll walk out this way around.
Yeah.
I'll do that.
Are you a Zoom expert or no?
Yeah, I
Yeah,
can, yeah,
okay.
that's how I did COVID for what,
Now
half a
it's
year.
gonna get bumped out.
You guys don't have
Right,
those
right,
around.
We'll do that.
I'm saying after.
I'll be ready.
All right.
And then one of those, you'll want those for later.
So I think
Yes.
if you share and you click this little button here, it takes away the big thing and then that way.
That works.
Okay. Perfect.
Sorry, virtual people.
Okay. Do you want this, hold up to where you go? There.
No, that's fine.
Okay, all right.
They can pull it up virtually through the Google Drive link you have. That would be
I think
great.
a lot of people from the other side are gonna transition. I think. We'll see.
Okay, so I'll let that sit there and I'll move myself up here. I might have Brian, be my clicker, just so that I can float around the room a little bit.
You know, I wanted to see before you do that. I was just gonna look at that video.
So it's not.
I just wanted.
Okay, I'll be back.
I just wanted to. I would.
I had to have Abby also. I don't know.
After a couple years.
So now.
Well, this is like decades old, so it was like the original furniture at the therapy office, and then my husband transitioned full. He doesn't work for some years ago. So I'm like,
MVPD friends that
One thing that like kind of really where this school against Texas, because I was always like, you know, I want to do this because I want to. We didn't know anyone, but my sister.
actually, let's do it.
With lots of handouts, everybody gets at least 5.
Yeah.
I think some of the people, some of the other people are gonna switch.
Started fire like.
Right, so you're not like. You're where?
I initially thought, well, I thought because only one school gets it.
I don't know, you can be if you want to.
You're.
I was gonna. Like,
Oh, and
Your clicker?
You're my clicker also.
yeah.
That's another thing.
I've turned it on.
Oh,
I don't realize, I never like thought about it. If it's only-
Where's those cupcakes? Are they breaking up there?
Right now.
Look at that.
I was on it.
Just enough for them.
There's still a
Huh?
lot more. I'll get my cupcake after, like,
Yeah.
otherwise I'll be on a coffee, the sugar high. Already talking fast.
So once you change the picture watch.
Oh, yeah. My problem is I would be able to go home and I'll think about, oh my God, my life. I would think about that like. I think of all the
That makes sense.
That's actually nice, like.
Maybe it's not.
You know.
There's a way to
And
come
that's
in.
separation.
Oh, I like mine, right, like, here's this one, I like, you know. I know.
My goodness.
They're scared of that.
I'm surprised.
Just keep tapping it.
Hello, we're gonna go ahead and get started because we have, what, 50 minutes and we don't want to.
A lot to cover.
Yeah, so the first thing I'm gonna do is I have a little thing I'm gonna read to introduce you to our speaker. Jamie, this is Jamie Myers. She's a 2009 graduate of this program. She has practiced in multiple settings, including inpatient rehab, skilled nursing, and home health over the last 12 years. Most recently, she was the OT clinical specialist and dementia education specialist for Continuing Healthcare Solutions, where she provided specialized education and program development for over 500 buildings in the United States. Dementia affects 1 in 5 people. Having been affected personally and professionally by the disease, Jamie knew that there had to be more positive way to provide care to those living with dementia. She received her certificate in positive approach to care, independence trainer and coach in 2016, and has since worked closely with Teepa Snow and a PAC team to continue their work. She is currently in an apprenticeship program to become a positive approach to care mentor, which would provide education and skills to people internationally. I'm sorry, I'm trying to read that. My arms aren't long enough. The PAC nomination, or the PAC mission, is to use our talents and abilities to develop awareness, knowledge, and skills with all people that will transform what exists into a more positive dementia care culture. I don't know anything about this, so I'm excited to learn myself.
Yeah, so has anyone ever heard of Teepa Snow?
I have, but I don't know much.
So
about it.
Teepa Snow is an OT by degree. She is actually from West Virginia, not too far from Morgantown. She now lives in North Carolina. But she developed a program, Positive Approach to Care, that you see here. So what we're going to dive into first is her Teepa's GEMS, which is basically the staging. We have all these other standardized assessments. We're going to sneak a peek at those and then compare that to the GEMS, which she came up with. So it's all about creating a positive language or a positive culture for people living with dementia. So what I want you guys to do, and if you're joining us virtually, go ahead and write down on your paper down in front of you, rating yourself and your knowledge, awareness, skill of working with people with dementia. 1 being, okay, I know it's a diagnosis, but other than that, I have no skill yet, I'm working on it. All the way up to 10 being, I could sit down and you could run this for me. Don't worry, I rated myself a 10 going into the course and went, oh crap, I'm not a 10. So go ahead and rate yourself. If you are virtually, go ahead if you want to and log that in the chat. And I want you to kind of keep a hold of that number as we go through and then kind of check back in on yourself after the end of this and see what happens with your number rating there. So go ahead and switch us to the next one. So Teepa created the GEM state model out of a need for a respectful, non-number-based system that emphasizes retained abilities, interest, and what cues and supportive environmental features can be useful in supporting people living with dementia. Initially, there were 3 systems to talk about the progression of dementia. You've probably heard of these: early, middle, and late. And the first level, in early stage, you were able to live alone. You just needed some help, maybe organizing your meds, maybe someone to come check on you. And the middle stage is when you typically would move into an assisted living or a long-term care setting because you're needing a little bit more help. Someone may have to help you bathe, organize your day, check in and provide you with your meds to make sure you're taking them instead of just organizing them where you can take it over. And then the third level is when you need total care. You need someone to take over the basic skills. You're having trouble initiating, sequencing a task, terminating the task, and then transitioning to the next thing. You have no flow throughout your day. At that point, you need total care. Then there's another one that we talked about, came the Global Deterioration Scale. Who has heard of that? Show of hands. Okay, some of you may have, some of you not, some of you virtually probably have if you're practicing in long-term care. So that one was created, it's known as the GDS for short, by Dr. Reisberg. It is a numerical system, a scale of 1 to 7, focusing on loss. What can't you do? What won't work anymore? It's global deterioration. Things are going downhill very quickly for some people. So you start at a 1. At a 1, you're intact. You're good to go. You might need some cues here and there, some reminders, some compensatory strategies. And then it goes all the way down after that to 7, where you are ready to die. The next one that we use as a cognitive disability theory, who has heard of the Allen cognitive levels? Yeah, that one you're probably hearing a little bit more of. It's OT based. And I really like this one. Claudia Allen came up with this one, and it's a little bit different. It's a number rating system, but it is the reverse of that number system. So it's 6 stages starting at a 6. You're independent, you can function all the way down 5, 3, or 5, 4, 3, 2, 1. And what it looks at that varies it from the GDS, that parts of pulled into this gym state model, is that it looks at abilities. And then it also looks at, okay, what can I do with the abilities that remain? And what tasks can I do with that? What environmental support? So it's starting to pull in more like the OT base, the function base. What can I give you to help you go? But you can kind of see the problem if you're using these number-based systems. Who here would rather be in 1st than 7th? Who here would rather have 6 of something than 1? And they're flip-flopped, right? So you can kind of see why this is really confusing, especially if you're talking to other clinicians. One may be using the GDS, one may be using Allen cognitive levels, and you get all this mix up. There's not this fluent interdisciplinary or even common lingo that establishes everyone as valuable and unique. So TIPA began to look at dementia as it isn't less valuable or different, because people get funny when you start doing a number rating system. It looked at, okay, colors, because we all like to do visual data first, is the way our brain perceives. Then auditory is the next thing. If you hear something, then you look to it. So something visual, okay. And then colors are good, right? So I need something visual. I may need something color coded. What can I do that places each person as unique and different throughout the stages, because dementia is different, it's a disability, but also makes them valuable. Then she went, okay, I think of gyms. Each gym is different. There's many different colors. They're each formed uniquely. So then she started going, okay, maybe I can look at do this with me, what support I need, and the just right care, because each gym is cared for differently, allows that person in that state to shine. So that's how she created each gym state requires just right setting, just right care, following a verbal, visual, and when those two meet and I get acceptance, then do I add the touch, so that each gym can shine and encourages in the moment assessment of ability, and accounts for that chemical and structural change in the brain as well. So what I want you guys to do now, go ahead and click to the next one. Here are our current screening and assessments that you often see if you're in a clinical setting. So we've got the screens as the mini-mental, the 88 interview. You'll notice some components there, the animal fluency, how many animals can you name in a minute, the clock drawing, the slums. You have all of these screens that you can look for that can assess if you think something's going wrong with dementia that's present. Then you have the full-on assessment. So the MOCA, the BCATs, and the NOMS, those ones are all asterisk because you have to be certified in those now in order to do those. But you also have the ACL, the GDS, and the FAST that are common ones to use as well. BCATs and NOMS predominantly speech, but when it comes to cognition, OT and speech make great collaborators, because speech can dive into the heavy cognitive components. OT can take that information and assess it during functional activities. So your regular ADLs or your leisure activities, all of those. So can anyone else tell me or give me an example of things that you've noticed being used in your practicing or in your clinical settings to assess dementia? Anything that's not mentioned here? If not, that's okay. Why do you think, just give me what I told you here, between these assessments and what you're briefly getting to know about the gyms, what do you think is so different about the language with these assessments versus the gyms? Go ahead, you're just speaking.
You're not on a scale like competing to like get better or get worse. You know what I mean? It's
Right, so
more
you're
just
not
like-
numerically trying to compete to the next stage and be at a better point. Right, dementia is very fluid. It is very a state of being in the moment. If you've ever had personal or professional meeting with someone with dementia or worked with them, you're gonna notice it fluctuates throughout the day, throughout the hour, throughout the week, throughout time. And it can also be influenced by internal and external stressors. So if there is a UTI going on, if there's something else internally going on, or if there's too much stress externally, too much stimulus going on, you'll notice a fluctuate. So that's why you have this circular model that TIPA created of assessing it in the moment per activity, per time that you're going into with it. So think about if you were a person living with dementia who is aware that they have dementia, 50% are, 50% aren't. How would you respond to being identified as a gym versus being identified as a number or a stage? You don't have to raise your hand, you can just speak out.
Number's more negative.
Yeah, so a little bit change in the lingo, the positive lingo, focusing on I'm a gym, not I'm a 6 on my way down the train. Yeah, great. Next slide, please. So now you're gonna see the wonderful team at PAC has put in a lot of work on this. And you guys have copies of these as well to use. Created this flow chart for us as practitioners so that we can compare the gym state to the other familiarized assessment. This comes in handy when I am talking with the physicians at the facility, or if I'm talking to other disciplines, and I'm like, okay, well, when I scored them, they were on a GDS at a 4, and then my speech therapist is like, oh yeah, I have them between a high and a mid 4. So then on the Allen, so we're kind of right in line. Or if you see here, I've got them at a 6. Yeah, I have them at a pretty high 3 or so. So we know there's a common lingo. Then what it does is you notice the grading of colors, they can kind of blur. So maybe Mrs. Jones starts out in an emerald or starts out in this 4 range, but then as the day goes on and the day wanes and Becky came in and Becky upset her and she got upset and now she's feisty. Now she's switching more into this other gradient shade of amber, which we're going to learn about. So my goal for you is to really be able to incorporate this in what you're already using and take it that one step further by looking at the abilities that remain, because we've got to stay focused on making a goal, right? In order to treat, we have to have goals. If we're only focusing on what is lost and not what remains, it makes it very difficult to come up with a functional goal that's achievable. We're not going to make them better. We're going to make the support and the care better to facilitate them to shine and do what they can in the way that they have with the skills that are left there. So next, there are 6 fluid cognitive states, like I said. Within this model, we begin with sapphires, then it goes into diamonds, emerald, ambers, rubies, and pearls. So each one I'm going to go through with you, and it was chosen carefully to represent the person living with dementia. So the very first one is sapphires. It is true and blue. So this is everybody in this room. If it's a good day for you, you're sapphire. Me, I'll get there before the end of this presentation. I'll probably be in the next stage as a diamond. So this is us on a good day. There is no dementia present here. So I want you to get out. We're only focused on dementia right now. We're focused on a cognitive state. So does your cognition, does your state of being change throughout the day, throughout the moment? Yes. So when we're clear blue, when we can reasonably and rationally decide things, when we can also see it from another person's perspective, we're in a sapphire state. This is where no dementia is present, or you as a caregiver or you as a professional can be in the right state of mind to help someone in those agitated states later on. Next, these are probably one of my favorite top 2 to work with, diamonds. So tell me what color a diamond is. Clear, clear. So they're clear and sharp. They're formed under pressure. Do we know how a diamond forms? It's formed, it starts out as a piece of coal through pressure and pressure and pressure. It finally forms into a diamond. So they are some of the most rigid things in the world, but boy, are diamonds pretty and they're flashy. They have many, many facets to them. They can also cut you to the core quicker than anyone. And if you've been around someone in a diamond state, you'll know they'll be nice as pie to your face. And then they're gonna cut you like that because you're pissing them off, right? We know these people. Some of the people never go beyond this state. They never reach a true sapphire. So you'll also find clusters of diamonds together. They're usually very social. And there's usually a head diamond. We call them the mean girls table if you work in skilled nursing. You know what I'm talking about. There's a head diamond and there's lots of other little diamonds around them. And they're gonna point and judge everyone else around them on what they can and can't do. And they're gonna point that out and they have no problems telling you because, well, I mean, why did you eat that cookie? You knew you shouldn't have had it. And well, you're gonna put on weight. I don't know why your ass is so big. That's your diamond. So when you look at your diamond, these are also ones that are very, very worried about finances. That's usually a bingo. They're searching for the authority figure. They're focused on finances. Do I have enough money? Is this going to cost too much money? I don't know if I want to do this therapy session because I don't know how, does insurance take care of this? Are you sure about that? I want to speak to the head of the nursing department because I was supposed to have my medication 10 minutes ago and she's late. Well, now Mrs. Jones, she has like an hour window. I don't care. She's just incompetent. That's what it is. So we know these diamonds. So diamonds are a girl's best friend. Like I said, they seek out the boss. Sometimes it's us. Sometimes it's not. You'll notice they will not want to work with a CODA or a PTA. They want to work with the head therapist who's in charge. And if you aren't that person, you're not going to trick them and think that they are that person. So they can be absolutely charming. And like I said, cut you to the core. We also have what's called diamonds in the rough. Has anyone heard of those? Watched a lot way back in the day. So those are the ones that look absolutely terrible in the outside, but that's just who they are. They've never really cared about that outward appearance. And you yourself can also turn into a diamond. So diamonds are formed under stress. And then do you ever notice the instant you turn into a diamond? Anyone? Anyone have a boyfriend, girlfriend, friend, roommate? And they've left the dishes out. That's the third day in a row. For me, it was last night when I was trying to load the car and get to dinner on time and finalize my speech. And my toddler is taking off her clothes. The 8-year-old is screaming that he's lost the iPad and it's not charged again. Oh, it's so tragic. And then my husband's like, why does it take you so long to get out of the house? I'm like, maybe if you helped a little, I can do this. And then 2 minutes later, we're in the car and I'm like, listen, I'm sorry for snapping at you, but that's the big key for a diamond. But you forced me to it because I was stressed and you didn't pick up on it. So the good thing is for me, I can take a couple deep breaths. I can see it from someone else's perspective. I didn't ask him for help. Therefore, he didn't know to take help or to come help me. I can switch back into a sapphire. However, as the disease progresses, that early stage, they can go from a diamond to a sapphire. But as it progresses more strongly into that diamond, they aren't going to be able to come out of it. So just looking at that, can someone give me, oh, that's okay. Can someone, and you've got some cheat sheets there in your paperwork, give me a characteristic of a diamond? Don't all shout at once, it'll get awkward if you don't talk. Bossy. Yes, they're bossy, just shout it out. You don't have to raise your hand.
Can't find fault in themselves.
Yes, they're perfect and I don't know why you can't see it. Yes, so they're also very, I've always done it this way. And you're like, no, we haven't. We always do it this way. And they're like, no, I don't know what you're talking about. We've always done it this way. And then what do? We go from sapphire to diamond and we start arguing with them. No, that's not the truth. And so they're going, oh, that's their truth and their moment and validating. Very good, guys. So now turn to the person next to you. And I want you to discuss for just a second. I'll give you about 30 seconds or so. Think of a change in the setting or the environment that might be helpful for a diamond state.
These people might have to excite.
Yeah. Awesome. All right. So what does this mean for us as care supporters or when we're offering care to a diamond? What do you think that means for us? So we're gonna have to make it, whose idea? Here's my agenda. Am I gonna come in and shove it in Olivia's face? No, I'm gonna have to go, hi, Olivia. It's Jamie. How are you today? Good. Pretty good. That's great. So we need to get two things done. Would you rather wash up first? Or would you rather go to the bathroom?
Wash up.
So what did I do to her? I gave her an option on who's in control. Me? She is. Well, technically, she's in control, but I gave her two things that I needed to get done, right? Either way, I'm gonna get her in the bathroom. Then we're gonna decide what we're gonna do. I'm not gonna go, would you like to wash up today? What are you gonna say if you're a diamond?
No.
No. And then I go, oh crap. And then I turn diamond because I'm like, I gotta get an ADL, I've gotta score this and I gotta move, we got stuff to do. And Olivia's now like, you're not getting me in there even if you try. Because I've already told you no, now you're just gonna piss me off and I'm gonna refuse. So we've got to put the ball in their court, come in with multiple options, take your little agenda, put it in your back pocket and go, okay, here's an either or. Or here's three things we gotta get done this week. Here's how we're gonna do it. You pick which one you wanna do first. Awesome, so let's move on to the next one. This is the first in our stoplight sequence. So green, emerald. What does green typically mean? Go, yes. You guys are getting it already, good job. So what's the difference between a diamond and an emerald is that you have some color going on. The color is green, so all emeralds are on the go. They aren't sure where they're going and they're going back and forth in time. So these are the beginning of those hippocampal changes that you're going to notice big time and pick up on, and they can't cue themselves like a diamond, but they're losing the distinctness. So your memories, do this with me. I have a memory of when I was 5, and then we went to Disney when I was 7. So I have those clear cut, and then we went when I was 13, and then I took my kids, right? Disney changed a lot in those years. Well, when my hippocampus starts to fail me because the brain is in brain failure with dementia, all of those layers do this, get jumbled up. So they can't make those clear cut distinctness of those layers in time and place. So they like to stay busy, but they're flawed. Just like all true emeralds, they're naturally flawed, not the man-made ones, but the actual true emeralds, there's a flaw. Sometimes it's so deep inside, these are your 50% that they don't even know it's there. So some think they're fine, and theirs are your ones that go, I can do this, I don't need your help. I don't know why you're coming over to me, I don't need your help, you're stressing me out. And then you've got the opposite of those. What do I do now? You're gonna regret sitting in the seat. It's okay, I'll move on to the other. Can we play bingo? And you're gonna go, we just finished bingo. Was I there? And you go, well, you just won 3 rounds of it, Gladys, right? Or you have the, honey, can I trouble you for some food? And you're gonna go, Jamie, you've eaten 3 times today. So at this point, we always think of weight loss, right? With dementia, we're not getting the protein. At an emerald state, what's really neat, you can also have weight gain. They aren't able to tell, or their amygdala isn't regulating them as much. They aren't understanding that they're on that thrive to survive, and that's going hard. So what they're in this phase, they get weight gain just as much as weight loss because they can't tell that I've filled myself. I just know at noon, and I happen to eat at 10 or 10:30, at noon I'm supposed to eat, and I can't tell that I'm not hungry yet. So kind of cool there. So kind of looking at this slide, or if you want to cheat and look at your little colored flow sheet there, what are some abilities? So I told you what some things are lost. What are some abilities that are still present at an emerald?
On the go with purpose.
Yeah, so I still have a purpose. I still want to do things. And most of the time I can do it if you show me how. I may miss a step here or there, but I mean, for the most part, I can get myself dressed. If you go, hey, here's your outfit, or you tell me, hey, let's go pick it out together. Yeah, good. Can someone give me an example of what changes in this setting or environment we should start thinking of? Remember, we're creating the right setting and the right care to let this emerald shine real bright.
Decorating for like a specific holiday so they know like the seasonal time.
Yeah, so giving them a visual cue by decorating for the holidays that that's coming up, yeah. Or schedule routines off of that. Posting up, here's your daily skill or daily sessions. My grandfather is actually an emerald. He's at the VA. He is very, very much independent with most things. He cannot regulate his day at all, can't keep track of it. But if he looks at a schedule, he knows my grandmother has FaceTimed him in the morning with activities. Then he goes, oh, okay, she did call me. And then he'll go, oh, I'm supposed to be at the PT gym for the bike at noon. And he can look at this and go, or if he goes outside to ask, when can I go home? Why aren't they coming to get me? I did all my stuff. He thinks because he's at the VA that he's back in the military. That just happens to be where he's at, and that's fine. We let it go because what harm is it doing, right? But he can go out there and they'll go, oh, Dawn, you have a calendar and on your wall. He'll go, oh yeah. And they'll go check that out and see where you're supposed to be. And then he can go back to his room, and that keeps him from following these poor nurses all the way across the hall. Yes.
So how would these emeralds function if you gave them like tasks that they had to do throughout the day that you didn't give them the time to do them?
Great question. How do you think they would do?
Probably not that well without time, but at least they know what they need to do.
So are these emeralds at home? Or they're in a facility? They could be both. I mean, you could be at home, any of these stages. I've seen them go to home or facility at either of these. Is time the priority of getting it done, or is it filling the moment with something that is meaningful to them? That's my question to you. When you think about activities and you think about doing it, we tend to put the focus on here is the schedule and it's important we stick to the schedule, and the schedule is what rules the world and keeps it going. Is it that way for the person that is flawed? Yeah. So we're going to switch your brains a little bit. I have to do this with nurses and everyone else too, so don't feel like you're the only ones that I'm throwing you a giant curveball with this, because it really does. They want to go, okay, give them a schedule and stick them to the routine. I'm like, okay, we have routine A, B, C, D, and so forth down the line. So that way we've got plenty of meaningful activity and purposes based on your ability that allow you to feel like you're successful in your day, because that's the true focus. Yes. So what type of challenges do you think arise with emeralds? This is a biggie, I'll give you a hint. So we start to see incontinence pop its head up here and not being aware. My sense of smell is starting to go a little bit. I'm starting to lose some skills. I can still do most things, but I may not be aware that I have become incontinent, right? Or I'm starting to not dress myself as frequently. So this is where you start to see bathing issues pop up. Because if I'm in a facility or when I'm at home, I didn't change into PJs last night, and I wake up and I'm in the same clothes, then I go, because I'm all about visual, well, I must have gotten showered because I'm dressed, right? Okay, and there's a lot of visual stuff. We're gonna get to that later. I wanted to go through the stages first, and then we'll go into the vision changes. Yeah, so we start to see those changes. You're not gonna do it for me. I still wanna do it myself, but I'm making a lot of mistakes along the way. Good, so next, what comes next in the stoplight sequence? Green, then yellow. The next gem is amber. So this was specifically selected because it's very unique in how it forms. Does anyone know how amber forms? You too young for Jurassic Park. So it forms because sap runs down a tree. Something gets caught in the sap, and then more sap comes over top of it and over top of it, and eventually and gradually it hardens. So it's formed because something is caught in a moment of time. So that's where this person lives, in a moment of time, not the future, not the past. They're right in the present. And it is all about what does it feel like? What does it look like? Do I want to do it? Don't I want to do it? I have absolutely no safety awareness. Prefrontal cortex is not as active right now. In midbrain, that amygdala is driving the ship. So it's all about sensation here. But the problem is I may not have much sensory tolerance, right? Oh no, daddy, no, right? We hear those. If you've ever been in skilled nursing, you're gonna hear a lot of those. So I may need something, and that's when I start doing things. Oh, look at that. Wonder what I can do with this, right? So I may have curiosity is still intact, but I don't have the safety awareness to know better, right? These are your people that you'll notice at the nursing station. They get the seat right up front because they don't behave like we think they should behave. So I'm in my chair and I'm scooting and I see that food over there, right? Sensory is telling me, my amygdala is telling me that looks good. So I start going after it and then my chair gets stuck. I don't realize I can't walk anymore. So I've had something else go on physically. I'm not strong enough to do it. Guess what? I get a chemical rush because that looks real good. And I get up, and because I'm not sturdy and I'm not aware of myself. So this is the phase you get a lot of falls. You get a lot of elbow blowouts. You get a lot of hip fractures, head contusions. I am also the most likely, because you're gonna go, Jamie, no, Jamie, sit down, Jamie, we don't do that. And here I go. And what are you gonna do to that cupcake if I have swallowing precautions? What are you gonna do? Go ahead. You're gonna take it and I'm gonna go, right? Because I wanted that real bad. And me personally, my amygdala doesn't go fright or flight. Sorry, I'm in fight mode because I wanted it. And that's what I want. So you'll see those amygdala responses that we talk about. You'll have fighters, you'll have flighters that just, the world's just too scary and they internalize it all. So those are your ones that are passive. They'll let you do everything, but you'll notice those signs of distress, increased respiratory rates. And you'll notice if you really become aware, they're not comfortable. They'll let you do it, but it just wrecks their entire world. Or you have the ones that are in fright, the screamers, okay? You're not hurting them, but it's overwhelming me sensory wise. I need some sensory, but I can't handle too much at one time. And that's me starting to be in distress by acting out. Because guess what? Now I'm labeled as behavior issues, and you're probably gonna send nursing to go give me something to calm down. Yeah, well, did I do that? Or did I react to how you reacted to me? Because you went diamond in the moment and took it away from me. Same thing if you try to get him to sit down. We get a lot of this. Come on, right? Who wants to be dragged from the back of their wheelchair? So this is what we're gonna start teaching you guys and what positive approach is all about. It's not necessarily about them and their reaction. It's about how we're responding. That starts to take away their dignity and make them be further in their skill loss because we've stressed them out to the point where an emerald is now an amber. And when I'm in TIPA conferences, I go from a sapphire to an amber real fast because I know she's gonna pick on me. But it's fun. So at an amber phase, I am the hardest one to take care of over a 24-hour period, right? You're thinking about all what we just went over. I am most likely to injure myself or injures others by not meaning to. So all of my mistakes at this point, I can't hide them. I can't talk you out of it at this point. I'm starting to lose a lot of circumlocution. So I'm talking around the words. Give me that thing of a jig. But at this point, I can't tell you enough about it to get you to where I want to be. So you're confused. I'm confused. You're frustrated. I'm even more frustrated. And it's just going downhill. So I would start by using tools and then I stop knowing how to use those tools. So you may see me holding my spoon, but then I'm eating with my fingers and you're like, what is going on? I know she knows how to use that spoon, but I'm losing object recognition. So we call this object confusion in TIPA lingo. We try to keep it very basic. So then it's not just a professional lingo we're speaking, so everyone on the team, no matter their educational background, understands what's going on here. Or I'm drinking from a cup with a straw, but I am pouring it and it is going everywhere. And you're like, what? Because you saw me 10 minutes ago, pick up my drink and suck out the straw, and it was fine. So, but in that moment, I couldn't do it. So these are very caught in the moment. So give me a characteristic of an amber. That's a long time. We're doing good.
Not really cautious about what they're doing.
Yeah, so no safety awareness, but very curious, right? So think of a toddler, not to compare them to children because they're not, they're adults, but think of a toddler. Prefrontal cortex has not developed, so, but what do they have? Curiosity. Yeah. So what cues might be helpful in this setting?
These like signs for like, red, green, yellow, whatever things they shouldn't be getting into, have like a red sign on it, red dot or something. Or green, like a place that they can safely manipulate. Not like hazardous.
Yeah, good ideas. So stations, color stations. Yeah, that might be good. Think about too, if they're curious in their setting, having multiple stations of things for them to do that are sensory, right? There's not necessarily a right way, wrong way of doing it, because I can't get all of that, but I can enjoy the sensory aspect. Yes. So what challenges arise with a ruby, or sorry, with an amber?
That uses them hurting themselves.
Yeah,
Others.
yeah, it's very not how I should be acting. I'm me, but I'm very different at this phase, right? I'm a high risk of hurting myself. I'm at high risk of hurting others. You're a behavioral issue, right? When really I'm reacting to my environment because I don't have the skill to think reasonably and rationally to respond. Yeah, you guys are getting it.
Just whenever they start to wonder as well.
Yes, so I'm very curious and I'm wondering. So your emeralds start to wonder, but they're usually going to seek out someone to help them. Your ambers are just into everything. Yes.
So like in terms of memory, like because they're very like caught in the moment, like how well do they remember other people because they're like so focused on the time that they're in?
So this point, you're going to hook onto those strong emotional tied memories. Now, they may remember people further from their past, but it's in that moment. So I may remember you now, but as we start talking, I don't remember you. And you start to see a little bit of that rear its head in the emerald phase, but definitely as we get to the ambers, I remember how you made me feel. I don't remember you. So you have a little bit of recognition, but it's starting to fade. But if you made me feel a certain strong way, like if you were my spouse and we really loved each other, seen some spouses that really hated each other, and it goes back to that. So I actually had a lady come up to a thing I was doing at a library, and her husband were first and second wife and husband together. They were married, got divorced, got remarried later in life. Pretty cool. But now he's in this amber stage, and his strong emotional tie is to 60 years ago when they were not in a good place, and he absolutely despises her and wants her out of his house and wants to know why she's there again because he kicked her out. Yeah, talk about having to navigate that every hour on the hour. Yeah. Does that answer your question?
Yes.
Okay. All right. Heading into rubies, the next one. So what color are rubies? Red. So they're red because at this point, red means stop, right? All fine motor stops for a ruby. If you thought it got worse at amber, guess what? It's just going to keep getting worse into the ruby stage. So all skill stops at this phase. What are these fingers? Do you guys remember? What are they called? You have these two that do strength, and these are your manipulators, right? These are your skill fingers. So I maintain strength. I can grossly pick up things, but I have no skill left. So eating, you're starting to see they're doing gross finger foods. But if it's skillful things to eat, like manipulating a utensil or manipulating grooming tasks, I'm going to need help with that. And I'll show you some cool things that you can do later on and how you maintain the skill for them, but they get to do the strength and you get some biofeedback there. So I'm also starting to lose, we don't just have fine motor skills in our hands, we have fine motor skills in our eyes, right? We kind of learned a little bit about that with the last presentation. We also have fine motor skills in our mouth. So you start to see a lot of chewing and swallowing issues here. Speech, this is a wonderful time for them to pick up and do a consult. If you notice a change in a progression from amber to ruby, get speech in there. So I may start pocketing foods. I may start spillage at this point. So you're going to notice a weight loss, most likely. If you see that, you're going to want to get in there and do a screen and see what you can do. I also have skilled fine motor movements in my feet, balance, right? Shifting. Rubies are really good about going one directional. So if I am going, I can't stop. So my protective instincts, those are out the window, that's a skill. But if I am seated, these are the ones that you see that can't figure out how to get up out. They can do this, or they'll even extend to stand up. So you'll see a lot of those movements. They can't initiate if they're stopped, and if they're going, they can't stop. They have a lot of difficulty turning. And if I'm going forward, I cannot back up. Lot shifts into the feet. You have fine motor skills on the top of your feet, the ball of your foot and your toes, where they're gonna have their weight in their heels. So you'll see, and you'll get the, hey, baby. I'm losing motor skills to talk. You notice a big jump in that there as well. But I'm strong and I can, and I've got strength. So what's she gonna wanna do here? Make her real uncomfortable. What are you gonna wanna do naturally? Pull away. Well, I've got strength. I don't have skill. Letting go is a skill, right? So she pulls to pull away. No, right? And they're gonna either latch on for dear life or they're gonna swing and hit you again, probably. But I'm gonna teach you those techniques with positive approach to care. And you can always look up TIPA's information online too and get some cool tips on there. But that is one thing. One thing that does stay in here is rhythm. So my language skills are on the left side of the brain is dying at a faster rate than the right side. The right side is where I maintain rhythm. So humming with me, I can sing. I can hum along to the tune. I can't sing the words of it, but I can do things to the tune of it. So we can use rhythm to use in our motion and our tasks. I can usually pick up things at this point, but I have absolutely no idea what to do with them. So I'm picking up a hairbrush and brushing my teeth, or I'm grabbing the remote and sticking it in my pants. I can't tell you how many remotes I found in underwear over the years. One too many to tell you about. So I have big, gross motor movements, and I can copy your gross motor movements, but I can't do the fine detail anymore. I also don't have sleep-wake cycles at this point. So I'm either up all night or I'm sleeping 2 or 3 hours at a time and then I'm tired, and all of these changes internally are happening to me. So I'm going to shift gears on rubies for a little bit. Tell me what is lost at this phase, because it's a big jump from an amber to a ruby. What's lost skill-wise? Yeah, go ahead, just speak out.
Some sensory needs because you don't have that manipulation.
Yeah, so my sensory, especially around my mouth, is highly sensitive. But the other things, I'm losing the skill in my hands, yes. Anything else you can think of that I told you that was lost?
Like social awareness.
Yeah, I have no idea what's going on out here. I am in here and focused, and that's all my brain can let me do. Good job. So discuss with your partner for a minute. I'm going to give you about 20 seconds or so. What changes are you going to want to do to their environment?
I have a question. Okay. So since they have changes in like eating and drinking patterns, is it typical to do like feeding tubes or
So sometimes it depends on what else is going on with them medically. A lot at this phase, you don't see the feeding tubes until they're starting to transition into the next phase, if that's what the family decides to go with. Ultimately, a feeding tube's not going to help. other than just prolong the inevitable. What you see a lot at Ruby is diet downgrades. So you see the regular foods go to Max Soft or go to pureed, and you see those changes first because it begins with a lot of chewing, fine motor, and then passing that all of the motor components to get it digested. So you'll see those things trialed first, or thickened liquids are starting to be introduced because I'm choking the fine motor of brain's telling me I need to breathe, but I'm shoving water down my throat and I can't regulate it. So then I and choke. Yeah. So you'll see that usually first.
How quickly do you see, changes from this Ruby state to the next one? Like once you start seeing feeding problems or choking and aspirating, those kind of things, how quickly can you see like
So that depends. So there are over 120, depends on where you look, but if you go by the Alzheimer's Association and those big words, there's over 120 plus types of dementia. And that doesn't include all their subcategories, which could get you up into the 400s. And each one progresses differently, timeline wise. And then you also throw in, if I have a feeding problem, then I get aspirational pneumonia. And then I'm not being cleaned as often as I could because I'm immobilized and I'm getting a UTI. Like you see how it compounds and then it changes the cognitive state. So it varies and depends. Most of the stuff, if you're looking at, I want to say and I'll use quotations, typical progression of say Alzheimer's type, because dementia is the big umbrella. And then you have all these subtypes underneath. If you look at a late onset Alzheimer's type, anywhere between 8 to 12 years you could be. So it's very, very different. If you're looking at early onset, it's going to progress much faster, or a Lewy body dementia, much faster. Frontotemporal dementias, or PICs is what it used to be called. Frontotemporals do a different subset of abilities and changes that are done. So it really has to depend on the type of dementia and then what else is going on. So this is just mainly looking at the cognitive state and knowing, okay, if I can quickly assess you and you're in this state at this moment, I know typically you're an emerald, but in this moment, I know we're not right where we need to be and you're an amber. I know how to adjust my skill set so I can help your abilities. I can either bring you back with me calmly to an emerald, or I can meet you at amber and we can still do things. Yes.
Is it effective to like try to put them on like in routines and patterns for like sleep wake and like eating and stuff like that? Or is it more just let them?
Yes, so you don't want to just let it kind of ride and let them be either understimulated or overstimulated. So you got to try to find that happy balance, but you also have to be very sapphire in the moment and know, okay, we're up, and know their history. Excuse me, know their history. So were they a night shift nurse? Were they a plant worker that worked the evening shift? Know their previous schedule so you can kind of work with that. Know what they were like. Interview family, get that history, and go, okay, was Jackie a morning person, a night evening person? So you got to do a lot of family digging, because most of the time by the time they get to you at these later phases, especially, they cannot tell you that. And even then, even at the emerald phase, how accurate is that report?
So if it's something that's like familiar to them, is there a possibility that they could get used to that in this stage, or is it?
As long as it's presented in the right way, yes. So again, it's getting used to, as in, will they remember it and retain it? No. Memory and retention, gone. But like I said, that strong emotional feel, if I like it, I'm going to continue to do it. If I don't like how it feels, how it looks, how it sounds, how it tastes, I'm not going to do it. So, and I don't have the ability to go, oh, rationally, I should probably do this because that's cool. Yeah, good questions. So what all does this mean with a Ruby and their ability to occupy themselves safely and effectively in their area?
We're gonna have to have stuff that they actually would like to do.
Yeah.
We're not gonna do it.
Yeah, at their skill level. So again, we went from, okay, emeralds could do some things, they made some errors, sensory driven ambers, and now we're to fine motor stops. So things that they can do strength wise, but not worry about fine motor manipulating. Yeah, good job, guys. All right. Now the last gym, and then we'll go into vision. To me, this is the most precious and special gem there is, and it is a pearl. So it's selected because of where a pearl was found. So I want you to close your hands like this. And I want you to look at this because this is the oyster shell. Has anyone ever seen an oyster shell? It's probably one of the most hideous looking things you've ever seen in your entire life, right? You would never think to open it up and there'd be this beautiful pearl inside, would you? So close it back up. What we tend to do at this phase, and you can kind of look here and see what I'm talking about. We get real focused on this shell, right? What am I going to do to the shell? How am I going to clean the shell? What's the shell going to do? How am I going to move the shell? Real focused on the shell without ever taking a moment to look inside and see that beautiful pearl, that beautiful person that's still in there, right? They're trapped in that shell. We start to look at it, and the body, I will tell you, really truly represents that shell. At the end phase of this, it is very ugly, very horrendous to look at times, almost sickening, especially for family, because that person is not who they remember at all. The body is being ruled now by reflexes. That is your big one at pearls, ruled by those primitive reflexes. The muscles are starting to contract at this. They are drawing internally. Everything is rotating. You're getting contractures. You can do your best to stop them. I used to torture a lot of old people back in my day. Splints on, Q2 off, range them, crank on them, and you hear them go, oh, right? And then you'll sometimes even get the occasional curse word. I'll save you from that. But you get that, right? The hitting, the biting. If you're leaning in too close, what's her only defense if I'm in here trying to get in? If her hands are contracted, bite, right? Because she's just trying to defend. She's in real distress. I'm trying to crank on things that are uncomfortable. I don't splint anymore when I get to this phase. And I've gone through some state audits, and I defended the reason why. I'm not going to stop this. This is neurological progression. The brain is dying. It's happening. Why should I torture them? I'm putting them in more distress when it's not done properly, when the splints don't fit, when I'm causing pressure breakdowns because they're bony, there's no muscle there for it to be padded. And I defend it, and guess what? Every state auditor I've ever come into contact with in West Virginia, Ohio, and about 42 others that I've done with trainings with my company have all said the same thing. You defended your point. And they were like, what? I cannot split people. I'm like, well, you got to split people for the right reasons, but you also have to look at it this way. Am I helping the person or am I causing more distress? So that's where you have to do that clinical judgment piece. So let's see, I kind of went on a roll there. So the tricky part is we want to focus on, it is just the shell. I can come out for little moments into the big world, and I can do it when I feel just right and safe, right? We get so focused on it. We got to bathe the shell. We got to stretch the shell. We got to do all this crap that we lose sight of the beautiful, precious pearl inside. So you know that you have to clean my peri area, but as you're doing that, you're having to pry my legs open. Positive approach to care looks at how can we do this using the right proprioceptive techniques in order to decrease the screaming, decrease the negative effects of having to do the care that we know has to be done, so I don't get a UTI and I don't get more breakdown, I don't get tunneling wounds. But it looks at how can we do this effectively, which are some really cool techniques, but I wish I had a full 3 weeks with you guys to share it, but I don't. There's some cool things in there. But mostly I am trapped in my shell. The challenge is for us as caregivers to figure out how to provide care to the shell and make those connections in those short moments, short periods of times when you know that the penny drops, cha-ching, and you know that they know that you know they're there. And sometimes you'll get the finger tap, and you may even get a, and then they go back in their shell. And it's not that that moment is any less special. I always get teary at this point because I've had these connections, and it does mean a lot, especially when you can teach family how to have these moments in this late stage. They're working on saying their goodbyes. And if you can teach them how to capitalize on those little moments when this pearl is just right and set up the environment so that it's making them feel safe, and you can go through and provide care at these phases, whether they're at home or a facility. It just makes this whole thing worth it in this last stage. Because at this point, we gotta focus on that tiny little pearl that's inside and trapped in that horrific shell and make the connection. So we have to change at this point because the gyms can't change, right? All right, so you guys have this nice little handout, gives you some really cool, quick bullet points on those gyms if you're ever in the setting and you're working with that. Down here at the bottom, you'll notice it goes into our vision. So it not only gives you the abilities or the likes, interests, dislikes here, but it also gives you a quick tutorial of the vision changes that come along. We hear a lot about the memory loss, the ability loss. What we don't hear a lot about is the vision changes when it comes to this. And it couldn't get any more confusing, but guess what it does? So let's go ahead and go to the next slide. So this is a normal, healthy 90-year-old man. Everybody knows what a PET scan is. Red means lots of good brain activity. Purple and blue, not so hot, go in there. Okay, so these are the occipital lobe. Normal, healthy 90-year-old man. 90-year-old man in early Alzheimer's. 90-year-old man in late Alzheimer's. And then that of a child. So you can already kind of see the difference. If you're just focused on these highlighted points, this is a more topical slice. This is a little bit more mid deep brain. So you can kind of see here's your amygdala, vision center, vision center. What's the big difference that you notice between just early Alzheimer's in the vision to late Alzheimer's in the vision? What do you see brain activity wise there? I heard somebody say it. There's more or less activity? Less, yeah. So our brain, because it's having to devote so much energy, look at the jump here, so much energy here and here that it stops cortical loss going on. Go ahead and go to the next one. So here's two 90-year-old men, like I said, healthy 90-year-old man that just happened to die of natural causes. And then this is the brain of a 90-year-old man with dementia. Alzheimer's type to be exact, late. What's the big difference you notice between that brain and this brain? Smaller. So if people walked around smaller heads, it'd be a whole lot easier to tell if they had dementia, right? Because he's in total brain failure. Look at the difference between the amount of brain that can process versus here. Big time mass losses, right? So primary way that humans like to receive data from their environment is visually. Now, we don't even have all of the other issues that we just learned about, or macular degeneration or glaucoma entering here, which is common. We just have straight visual processing. My brain just can't handle everything that's coming in. So my brain's going to selectively take it away and narrow it in until it can process what's in the environment. So we are left receiving less and less data from our environment when we need it most, right? So this is huge when we looked at connecting with a person living with dementia and providing the right support and environment in order to develop their care plans. So how do you think this is going to relate to our gyms? I'm going to tell you. Let's go next. So go ahead and stand up with me if you can. Space out so you don't knock out your desk marker there. Spread your arms out to 180 degrees. Wiggle your fingers. If you're 20s, you can probably see them. If not, bring them in where you can see them. All right, I'm already at 35 and I have a good 10 degrees that's lost. So now bring them in 45 degrees. That is 75 years old, no dementia present, okay? We've lost 45 degrees of our peripheral vision, right? So go ahead and make a big circle with that. What do you notice? I lose it at the top, the bottom, the sides. What do you notice I'm not gonna see unless I tilt? My feet. So guess what I'm gonna do when I walk? So I don't trip because I know it, because at 75, I can most of the time if I trip, catch myself unless I've got something going on, right? So by the time you're 75, no dementia, go ahead and stay standing up for a minute. Your visual field is somewhere around 45 to 50 degrees, or 40, sorry, less than 45 degrees from your 180. Now, between normal aging and a loss of 45, I want you to go back to that 45, bring it in another 20 degrees, 12 to 18 inches basically from hand to hand. And this is your diamond state visual field. This is it. Your central field is what you can process. It's not that it blacks out and goes away. This is what your brain's able to process in your environment. So we call this scuba vision. So go ahead and put up scuba gear. So you're gonna leave the nose piece out, right? This is what a person in a diamond state, 7 out of 10 do not have a diagnosis of dementia at this phase. So turn to your partner. And I want you to be right up in their business because you're gonna go, hello to your partner. So take a look around the room and see what you notice that's different about your environment. So use your scuba and then drop your scuba. See what's different that you're processing.
Move along.
This is a diamond state. So what you want to think about when you get in front of a person is they may or may not have dementia, right? 7 out of 10 here aren't diagnosed, but huge vision changes at just a diamond state. What you want to look at when you lean in, because old people can't hear, I'm visually attacking her already without even meaning to, right? I'm confrontational stance because I come in because I want you to see me. But with a limited visual field, I'm visually attacking you. So we call that a confrontational stance. We want to turn the shoulder and be in a supportive stance. Go ahead and you can try it with your partner as I'm talking. It won't offend me at all. It's kind of cool to see. Put up your scuba gear and have your partner lean in close and then switch to one shoulder away and see if it makes a difference in how you feel about them coming in that close. All right, so then we're going to go ahead and progress to the next gem, and an emerald at this state, we're going to go from our scuba gear down into what we call binocular. Holy moly, right? I already heard that in the crowd. This is what you said. Now do the same thing with your partner. Lean in, same. You can either be an arm length away. Notice the difference if you come in confrontational or if you come in supportive there. So at this point, I have either task vision or I have social vision, right? I can either, at this point, I can either do what I'm doing or I can talk to you. I can't do both at the same time visually. So if you're doing something with someone, let them focus on what they're doing, because every time we talk, guess what? Stop, go. And if I'm an emerald, you've got to re-cue me to get me started, or I've just blown the whole thing to pieces. Yes, so my brain just won't allow it. And your free time after this, I want you guys to try all these, try different things. Try brushing your teeth. If you happen to have like tanning goggles or something like that, try popping the eyes out of them and using tanning goggles. They work great for binocular vision. Try doing things, it'll blow your mind. So now, now we've moved to the amber state. I'll move quickly through this one. Okay, so we have binocular, but now wiggle those around. Now we have object confusion. Oh, Jesus, right. So now you're starting to see why things are getting so much harder visually, right? So don't worry though, I still have curiosity and I'm going to try to figure everything out, but I'm not going to be so good at doing it. Here comes the biggie, right? Using both eyes together is a skill. Rubies are coming along. Now we've lost the skill. So go ahead and cover your non-dominant eye. You've lost all depth perception. It's a skill. You're down to just a monocle, usually over their dominant eye. And it takes some digging to figure out what that is. So what I want you to do, something that is like a table length away over an arm's length, I want you to try to reach out, keep your eye covered, your monocle on as a ruby. And I want you to reach out and touch that object. Reach something at the far end of the table. Really go for it. It makes it really hard. Now can we understand why rubies are even bigger mess makers than the ones that were object confusing out of the amber? Yes, so this not as easy as it looks, that's for sure. We notice a lot of money to keep the toilet or chair in their monocular field. So you'll see these that come here and then they sit, right? And you're like, what? Early sitting, and it's like, well, I'm trying to keep it where I can see it. So you'll see that as well. Or not seeing food items that are right in front of them on the plate. So even if you're looking at your plate, I'm missing part of it. My brain just can't process it. So just take a look at your environment and kind of set it up that way. I even have an eye patch that I'll flip on and kind of do this to make sure, okay, am I really setting up the environment so it's conducive for when they're sitting in their chair or when they're at their bed? Can they really see that easily? So and then our final vision processing change, we're in a pearl state. So go ahead and put your monocle back up. And now I want you to take it and squeeze it in. That's where they're at. And then I want you to start shriveling up your body, go into those primitive reflexes. Now we see why it's so hard when you're like, and granted, Mrs. Smith is not sitting in her chair like this, right? She's got both eyes open. It looks completely fine. But now you see why she misses things in her environment or she's not engaged in her environment. So it's very hard. They notice movement at this stage, can't track it because you see how little that visual field is. But they usually can tell familiar and unfamiliar people, places, things, just very visual, very limited visual regard when and they are in that brief moment that it's okay to come up in the world. So I'm gonna kind of squeeze through here. We can treat this, go ahead, with knowledge, skill building on our part as the clinician. You can have some with a commitment to do better, being flexible in the moment, practicing giving support and compassion. So I'm going to give you a quick demo. Taylor, I'm going to have you, I picked on poor Olivia enough. You can go ahead and go to the next one. So we do this by the skill building of being a detective, not a judge, right? Okay, something's going on weird, some changes have happened. Let's dive in and see if any of these states are matching up. And we always want to give cues visually, verbally, and when we're accepted, only then do we touch. Because I'm going to tell you right now, if I came in with a touch, the third one, how do you feel about that when it doesn't feel good, does it? Right? I want to make sure I get visual regard, and then I'm going to give her an auditory. Hey, it's Jamie.
Taylor.
What did Taylor do? She reached out. So I can also use this as an assessment tool. I can see how long it took for her to process that I want this social greeting of a handshake, right? Pretty deeply rooted hand-eye coordination. It's in there. When I'm telling her, hey, I want to come into your space, is it okay, without asking? She went, okay, here's my hand. Then what I'm going to do, this is what we call our butterfly. You can try this at your table. This is the beginning of hand under hand. So when you're here, it feels awkward just to hold this, doesn't it? This makes her feel real weird. But if I come in to here, I'm gonna spin you around. This doesn't feel as bad, does it? We're kind of teamed up against the world here. And my hand is underneath, signifying that I am here to support you. I'm not here to control you, but I can help because I can hold on with my strength fingers, right? I can hold on. She feels comfortable. I'm not pinching down on her. I'm just holding it. And I can, I'm going to get in personal just to warn you. I can use my skill to button. I can use my skill to help dress, help groom. And she can tell me that's okay. Or if I go in too, she pushed back and I feel that feedback and I go, okay, it's okay for me to brush her hair. It's okay for me to button her pants. But if I go for the chest, I need to take it slow. And then I can use other cueing strategies. I can use other cueing strategies to help get her there. So that's just kind of a brief, go ahead to the next one. A brief of the skill. I could teach for days and days and weeks on the skill. So that is called positive physical approach. I come in with a greeting. I offer my handshake. If she accepts it, then I'm allowed into her space, right? I don't touch her or anything. I gave you a hey, and then we got connected. And then we're ready to do a task. We got to get connected before I can just shove an agenda. Good. So then that moves into that hand under hand, which we can use for connecting. I can also use that to help move you. So if you need to move, I'm going to jump a couple steps here. I can direct her with this. I'm pumping her hand. So I'm getting her attention. She's going, oh, her brain's going, oh, she needs something. She needs something. She's pumping my hand. I don't know what I'm supposed to do, but she needs something. Then I can use that as a rudder. So I can steer her around the room. And I can let her know right where I want to go without ever telling her, with what information her body can process and use. I can also tell her we need to bend down. And I can guide her to sitting all through that. So great for toileting ADLs, getting them through the moment. Go ahead and go to the next one. So with this approach, it is not about doing to the person. That's when we get the clashing. It's about doing with them. So we're doing the task with them. We're getting that feedback. We're offering those choices. Would you like to do this or this? Will you help me try? Olivia, I know you were just great at matching up. Like, you used to be a phenomenal housekeeper. I really need your help. They've destroyed my towel collection. Could you help me? Okay. So I'm putting the ball in her court. I'm giving her positive reinforcement. I'm building her up, because then you're more likely to come help me. So then you can start breaking it down based on those gyms. You'll know how far to grade that task for what they need to do. Good, go next. Then I've got some things in there you guys can look at. I don't want to dwell too much on this. Once you start to get that hand under hand natural for you, and it takes 4 to 6 weeks of really drilling it to build that new skill yourself, then you can start using what they call positive connections and positive action starters in order to make it all flow and be natural. It does take some work. It's not the way we're used to doing it. We hear hand over hand, and now I'm flipping the script and having you go under, right? Okay, next. And go ahead and go next. I already covered that one. So I just want to thank you guys for coming. I know geriatrics usually isn't like the, ooh, it's exciting. But as Tipa always says, dementia doesn't rob someone of their skill. It's our rob someone of their dignity. It is our reaction that does that. So if we can do positive approach to care and I can get that message out, let's change the world together. Thank you guys. Yes, go right ahead.
So with the visual, like, whenever you're like entering their room, is it better to
So if it's someone that you're just starting the evaluation.
It's like so.
And then you just start
I didn't even know which one you were.
Hopefully that was good. Did I keep you guys too long? I'm sorry.
I didn't even know.
I get really excited about it. Like I said, if you're curious, Tifa has a podcast. She has Facebook Lives every day, twice a day. She's got YouTube, and she's got everything. The team's awesome. You can go on there and see all different kinds of techniques. She offers a lot of it for free, and she is internationally known for doing this and spreading this word. She also does a national conference now every year. That's in 2 weeks. It is virtual this time if you want to hop on. I think students get either a discount or something. Don't quote me on that. You might even get in for free. I have to check. If you're interested, of course, get a hold of Brian and I can get more information to you guys on that as well.
Thank you so much.
Oh, did I get it? Did I get it all done?
I just saw a chat.
Yeah, somebody wants to switch.
See, I'll see you then.
Just telling her. You're on my phone.
Oh, thank you. There's so much information.
Oh, yeah. I'm halfway down on Saturday.
I know, I'm just trying to.
You guys are.
You don't have to switch, you can stay. You can stay or go, whatever you want to do.
When I see Dr. Seuss.
I'm here to support.
I want to find out about this, if I can get me an OT capstone student to help.
All right, we have.
Okay. So welcome to our presentation today. It's fairly casual. So feel free to ask us questions as we go. But we're gonna kind of talk about how we envision and how you can envision your future with an OTD student, and what they could do to help you kind of develop your practice or develop specialty areas.
Here, I'll change the slides.
It is being
Really
okay.
bizarre.
So here are our learning objectives today, is that you'll become familiar with the OTD standards for the capstones. We'll identify the various roles of how the capstone supervision is done, how the team works, and then we'll recognize some opportunities for capstone projects in the community. So let's dream. So, okay, all right, so. Like, yeah, okay. So, I mean, we've all had that, right? We've had that one project that we really want to do. Like, we really want to try it out, but because we have productivity concerns, because our bosses want us to be busy seeing people, we don't have that time to kind of implement that really cool program that we read about, or that we think would be really helpful to our setting. So does everyone kind of have an envision or have an idea of one of what those dream projects are? And would you mind sharing? Yes, go.
My dementia stuff, I have all kinds.
Mm-hmm.
They are working on getting it standardized,
Right,
which is quite the process. It takes lots of research and data.
right.
But getting it to a point there, it takes the students.
Yeah.
Helping with that.
I mean, and that's something that when we talk about what the areas are, doing research and helping to develop clinical research is something that a student could do as part of their capstone project. And we'll talk exactly how that happens here in a second.
Program development.
Yep, or program, yep, clinical program development, like if you want to implement something,
Right.
that would be something that's totally in the wheelhouse of an OTD. Brian, what would you want an OTD student for, do you think?
To help with research.
To help with research.
All the stuff.
I thought they were gonna do your job.
Maybe in an academic way they can do that.
Right, but like if you had a particular research project, like what we were talking about with the village.
Yes.
And that would be something that, yeah, they could do if they had an interest in doing fall prevention in assisted living. Assisted living sites are great places for OTD capstones.
Okay.
What about you guys? Anything? Even if you're in your recent clinical experience, since we know you're new here.
Mine would be like a, not necessarily return to driving, but some type of driving training post-stroke.
For sure, that's a huge need. Yeah. Kaylee? Anything you would like to have done at Ruby? But you guys are just too busy seeing people? Okay.
Yeah.
We're at Chestnut Ridge?
Yeah, I feel like there's a lot of Chestnut Ridge I
Mhm.
could do with OTDs.
Right, and it doesn't have to be anything that necessarily would be reimbursable. That's the nice thing also, is that they can do actual program development and help you develop that data to prove that that program is helpful, which then makes people more willing to invest money into doing that program. Got anything, or you just want to sit? You want me to leave you alone? Like, just pretend I'm not here, Diane. Okay, no problem. So really quickly, to talk about the types of OTD education, there's entry level and post professional. The capstone is a requirement of the entry level degree. And so those are the people who are currently in our entry level program, and it's highly controlled by accreditation requirements. So they have told us what we need to do, what the capstone has to be, what the timeline on the capstone has to be, how many hours it has to be. So OTD entry level programs are highly controlled by ACOTE, but post professional programs are not. Those are available in a variety of settings. You can get a variety of specializations, but they are not accredited. And so they don't have as many, oftentimes as many requirements as we do, because that person who's doing the post-professional already has their clinical entry-level OT degree. So they don't need to meet knowledge standards or take the licensure test again. So that's kind of the difference. Yeah, thank God. That's the difference between those two programs. So really quickly, this much I feel like I'm talking to, okay, I'm talking to one person in the back. Okay. Oh, there's people online. That's right. Okay, good. I'm glad to hear that. Okay. I'm like, cause he knows, and she knows, and he knows. Okay. So there's 3 years, the new education programs, we have a new OTD program, and we're doing an integrated MOT OTD curriculum, which means our MOT students and our OTD students are taking some classes together, and then they're separate for some classes, because there's only, out of all of the educational standards, only 25% of them are different between the two levels. 75% are exactly the same. So that's why we have a highly integrated curriculum. But we've also rearranged the curriculum to respond to the new ACOTE standards, and just to make the situation better for our students. I know a lot of people who are watching this right now are alumni, and you guys remember that we used to make you go out and like go live somewhere for 3 months and pay for that, and then come back here and pay for your house here, or your rental here, and you can't get a rental for 3 months here, so you're either couch surfing or whatever. And it was the cost added up. So the main way that we've changed this now is that the first 2 years are here on campus, they're year round. And you live in Morgantown, and almost everything you do is in Morgantown. Then you go out on your clinical year. So both level 2 fieldworks are now at the end of the curriculum. That frees us up for fieldwork placements a lot, because we don't have to worry about whether they've had PEDS class or they've had the hands class. They are fully ready to go out when they do their curriculum. For the capstone, it's in the 3rd year of the OTD program. It's after the 2 level 2 fieldworks, and it has to be by accreditation standard. And Sue Ann's going to talk about that in a second. The curriculum, the areas of emphasis, or what we used to call threads, hasn't changed that much. Evidence-based practice, occupation-based practice, rural practice, responding to the environment that we exist in here in West Virginia. Clinical reasoning, we've gone from 1 clinical reasoning course to 4 clinical reasoning courses within the curriculum now, and we use those courses to integrate a lot of the content. And so that the first 2 classes focus on the client being an individual. The 3rd class focuses on the client being a group, and the 4th one focuses on the client being a population. One of the big changes in the AOTA documentation, the OTPF, and in ACOTE standards is this concept of addressing all 3 types of client: individual, group, and population. And then professional identity has always been big for this program. Advancing the profession of OT, advocating for the profession of OT has been really big. I think the other main changes, if you looked at our curriculum, is that it is lifespan oriented now. So when they take an evaluation class, like what I'm teaching this semester, they've learned feeding and dysphagia for adults, seniors, and children. They're learning to do the DAISY, they're learning to do the school function assessment, they're doing GG codes, they're doing PDs, which is ADL assessment for pediatrics. So instead of creating kind of what we call fault silos, where they would say, well, I can't I can't help that kid get dressed. I haven't had peds yet. And it's like, it's getting dressed. You know, it's like, it's the same thing, but we kind of are like, I've not taken a peds class yet. And so we just kind of try to eliminate some of those silos by taking more of a lifespan orientation to it. We'll let you know how that works out.
Austin can let you know how.
Right now, it feels like it's working out pretty well. I just had a whole bunch of first year students look at children eating and diagnose what was going on, which was awesome because I looked at it and I was like, I don't know, that's just bad. I looked at the video and I'm like, no, that's just wrong. But it so far does seem to be going well. And it kind of means that our students are better prepared, we think, across the board. Accreditation for the OTD program right now, we are what's called an applicant program. So we have gone through the first stage. We've been given candidacy, we passed our candidacy. So we're going to have students in the programs for 2 years, and then we will submit our first major self-study, which is the first step to our on-site in November of 2022. And so a year from now, wow, okay. And then the ACOT people will be on site in August of 2023 to visit the program, visit with the fieldwork people, visit with our students, and then our first graduates will hopefully graduate in May of 2024. Yay!
Oh. Okay, there we go. All right. So for those of you who don't know, I think everybody here actually knows me, but my name is Sue-Ann Woods, and I will be stepping into the role of the doctoral capstone coordinator in January of 2022. So it will be my role to a percentage of my workday and my work week will be dedicated to establishing doctoral capstone relationships and overseeing those projects. And how I will be guided through that process is by the ACOT standards. So ACOT standards are available for free online. They're widely available. You can look them up. They changed in 2018. And if you were to go to the document, you'd see this is how each of the pages starts. And there's 4 columns because there's 4 points of entry for occupational therapy education right now. Entry-level doctorate is on here. Entry-level master's, assistant at the baccalaureate level, and assistant at the associate's degree level. So 4 columns. If you wanted to read them along the left, they'll have the code and then the description of how each level should be measured there. So capstone standards fall in the D standards. And there's also a doctoral capstone textbook that provides a lot of useful resources. So those are some guidelines for this process. So I thought it'd be really useful since you have your dream project that you maybe could implement. Well, what would the standards say that the student has to do in that process? The first standard says that the student has to have an in-depth exposure to one or more of these 8 areas. So if you were going to do something with return to driving, well, that would fall into the clinical specialty area of practice skills, but it could also be a program development. That was a program that your facility continued on and the student launched the process. They could develop research skills like Jamie was talking about. The area of expertise that she has needs additional research, and then they could pivot that and do program development for the people who work in that facility as well. So according to the doctoral capstone coordinators who already are working in these positions, theory development is the least popular area of emphasis. I can't imagine why. Some other examples, a student who identifies that they have an interest in teaching in the future could do a teaching experience with a faculty member where they learn how to develop rubrics, learn how to develop learning education programs. So lots of opportunities there. Furthermore, the capstone consists of 2 parts, the capstone project and the capstone experience. They have to complete a project and then they do the experience, which is 14 weeks, and it has to be started at the end of all of their coursework and their fieldwork. So they begin a planning process well before that, and we'll talk about that. But otherwise, if they were a master's degree student, they would be sitting for the board exam at that point. So they are well prepared. They're entry-level clinicians who are staying on an extra semester and have had extra prep work leading up to this to be able to implement this program. Moving on to the next standard, 1.1.
The doctoral capstone has to reflect the sequence and the scope of content in the curriculum, and it has to allow for development of in-depth knowledge. So it's not something that is basic, course level information. It's the opportunity for them to develop their niche role and to be able to use in launching their career. Moving on to 1.2, this is the standard that should alleviate some of the stress from you if you're interested in taking a student at some point. It's not all up to you. It is a team-based approach. So a collaboration between the OTD student, a faculty mentor for each student here, and a site mentor. Now, what's interesting is the site mentor could be one of you, but it could also be someone who has experience in that particular site, and they don't have to be an OT. So if they're at the homeless shelter, it could be a social worker, and the student is there providing the OT perspective under supervision of the faculty mentor, but it does not have to be direct, line of sight supervision like it does on field work. Okay. So there has to be a plan for supervision, and it has to be, thought out in advance. And the student starts working on this approximately 1 year before they begin the process. So they've fleshed out all of the literature, and they've got a plan, and then when they are ready to launch, they go. So it's moving on to standard 1.3. That leads us right into this. They have to do a needs assessment and a literature review, and they don't get to dream up what they think Jamie's site needs. They have to work and actually find a program that is really applicable and is useful. It's not just for the sake of the student, it's for the benefit of her clients or the population in her community. And the student's project has to have goals and objectives, and it has to have a way that they're going to be evaluated. It has to be explicit. Now, if you've taken a fieldwork student from Dr. Scaife, you know that he will send you the fieldwork educator packet, and that includes AOTA's review process of scoring students, and it's a standardized process, and they have to meet a certain score on each criteria. That doesn't exist for capstones, because if you think back to those 8 areas of emphasis, how are you going to evaluate someone who's developing a theory against someone who's running a program? Like, that seems wildly different. And so the way in which a student is deemed successfully completed of the project has to be unique to the project. The preparation of the project should align with the curriculum, but it has to be done before the 14-week capstone. So if you sign on to take the student, you have to start engaging with them about 1 year before they're on site. But once you get them, they're there for 14 weeks. The amount of time that they spend is highly regulated. So in D1.4, there's a valid memo of understanding. And if you're familiar with our fieldwork experience and having contracts, it's the same process. So it's kind of the legal aspect. Who's going to be supervising? What are the responsibilities of the party? If you have a more recent fieldwork agreement with us, our capstone agreement has been added into that. So Allison Pierce, who's here, is the person who handles these contracts for us. And our legal department has already added in. If your contract is not within the last probably year, it would not have that language in it, but it could be updated very easily to include that. Allison works hybrid. She's on campus twice every month, and she lives in Beckley now because she moved during the pandemic. She was able to maintain hybrid work, and so she's phenomenal, and she's available by email. And I would encourage you to reach out if you have either fieldwork or capstone questions for contracts. Standard 1.5 is that hour and week standard. So it's 14 weeks, it has to be 560 hours. And of that time, 80% has to be on your site. Okay, they can do 20% off site. So that could be getting supplies, doing a project that they don't necessarily need to be there for, but like working on literature, something, based on the site. So the field work doesn't count for that. So prior field work experience may not count for this. Okay, it's meant to be further in-depth new skills. Let's see, 1.6 says the student has to be mentored. So I cannot send them out to somewhere where they get to design it all by themselves. That's not the point. They have to have a mentor. And it has to be someone with area of expertise. So the person who is working at the homeless shelter is an expert in that site. They know the needs of their clients and they know what the current problems are in, you know, helping these people meet their basic needs. And that does not mean they have to be an OT. We can provide that OT supervision here through our faculty. Moving on to standard 1.7, and like I mentioned, the students have to have a formal mechanism for objective assessment. It has to be during and at the end of the process. So again, you know, it's essentially a rubric. They have to know what they're being scored on and it has to be clear. It's not a secret. Standard 1.8 says the students have to disseminate their findings. And so the doctoral capstone coordinators from across the country met and had a big debate about what the verb disseminate means and what really meets that requirement. And what ACOT reviewers came and said was that however you share your findings should be based on the type of people you're trying to find those findings. So if you're trying to share them for other OTs, well, you might want to present at an OT conference. If you're trying to share with other mental health practitioners, you might want to present at a mental health conference. And if you're trying to share with school system OTs or birth to 3 parents, you might want to build a website and you might want to present at a health fair. And so how you disseminate your findings is not legally binding based on ACOT. There's some variety in there, but it has to show this in-depth synthesis. So part of my planning process is actually as part of their skill building. Leading up to this, they're going to be learning how to build Google websites and building their capstone portfolios electronically so that they can articulate this information and provide skills to the sites that they go to that can be useful. So we gave you the opportunity to dream. We'd like to remind you that, you know, through these 14 weeks, you could make your dreams a reality with the help of a capstone student. It's not totally, it's not without work on your part, but I think that OTD capstone students with their time could change the world for West Virginia. You know, there's a lot of programs that need to be built where, as Dr. Marsh and I think Dr. Mandich and everybody said, you know, where our health outcomes are really poor. We have a lot of health disparities here, and there's a lot of need at every level. So I think we could make some big leaps forward in programming here. So just a reminder back, you know, these are the 8 areas that an OTD capstone student can spend 14 weeks. These are some examples that the capstone coordinators have shared at the national level that they've had very good success in their students doing. So they've had students develop more than entry-level knowledge in low vision and then develop programs at a skilled nursing facility, a home health and an assisted living facility, both at the individual level, developing the program for them, but also providing training for the staff there. Like I mentioned, yes, Dr. Steve.
Whatever you say about they could do administrative capstone, what can you give an example of what an administrative capstone might be?
Well,
Yeah, do you have a good example?
yeah, so, well, yeah, so like sometimes if you look at like our state OT association, like WBOTA, right? That would be kind of a mix administrative and advocacy because there's a lot of structure there that if it could be built out and supported by students, WBOTA itself could be a much more effective body.
Yeah.
And so that would be kind of a mix of an administrative or that, but like administration with, you know, just oh gosh, I'm trying to think, they talked about like supervising, one of the ones that we talked about was going in and supervising mental health workers in a certain manualized approach, and like building that out and building up the documentation systems for it and building up how it was going to happen. But they themselves didn't actually do the treatment, because they would have needed to be supervised by an OT at that point. But instead, they were kind of building out the support staff to implement the program and putting in all of the systems necessary to do that.
We're gonna talk about WVOT on the next slide.
Oh, okay.
Yes.
It's in our target.
Of course, I know Jacob's excited.
Yes.
Of course, some students identify that they might have an interest in becoming an academic as part of their future career. And so their capstone can be learning those skills here with us. So they can learn how to develop teaching skills, develop rubrics, develop learning objectives, and provide critical feedback to their classmates on their skill development. Well, it would be their classmates, it would be the class below them, or two classes below them even.
And it doesn't have to be at their home institution.
Correct.
Like I have a student who's reached out to me who wants to work on increasing cultural diversity content in OT education programs, which is not an area we're particularly strong at. And she's at Shenandoah, and she would like to come here and do that. And that would be a really nice capstone project for us.
And then, so here in Morgantown, my kids go to daycare, and they have been screened every year for free in their daycare by the speech language pathology students to see if they're on task or on track for articulation and language. But OTs could go and screen every kiddo, in Morgantown or their home county or wherever they're from for development, to see if they're on track for development. And then refer them on to the appropriate early intervention services. As I mentioned, WVOTA was here. I think there's endless opportunities for collaboration with WVOTA.
Not the president, but we'll take them.
If you think about the amount of time and energy and effort that goes into building out a conference, they could, engage with speakers, develop a needs assessment. What do the OTs of West Virginia want to learn about at conference, and what's going to get them there? And do they want it hybrid or virtual? And they can do all of that work and then execute it with you. And then think about what kind of skills they'd have and how they'd be able to, keep that going potentially, Here in Morgantown, the West Virginia Assistive Technology System, WIVATS, has a remarkable program. They have people who are assistive technology providers, and they have a humongous lending library of all this assistive technology equipment. And they have people come in and they show them things, but they don't have any OT perspective. And the opportunities there are remarkable as well. These are some examples of some existing WVU agencies that I have identified as potential places that we could collaborate with. So Country Roads is the young adult program here, where adults with intellectual disabilities are able to come to college and live in a supported dorm and gain independent living skills. That's perfect OT, right? And so Amy Burt and and Jacob are already involved with them at an appropriate level, but the OTD student could be there on an everyday level, reporting back to Jacob and Amy what they're seeing, and Jacob and Amy will be giving them, okay, try this, do that. But they could be there all day, every day for the semester. OLLI is the OSHA Lifelong Learning Institute, which is a wonderful group of older adults, mostly who are retired, but still want to learn new things. So they go to the old mall here in Morgantown. What, do you know about it?
No, I love it though.
Oh,
Yes.
I love
And
OLLI.
so every
I
couple
agree.
weeks, they send out a thing, an email that says, we're looking for highly engaging people to come teach classes to our highly engaging older adults. And they want to learn how to paint, and they want to learn exercise, and they want to learn all these things, but they also want to learn other things. cognitive things. They're people who are retired professionals, you know?
My vision for that one is that almost everyone who goes to Ollie drives there. And I really think that there's an opportunity for an OT doc, for a capstone to go to engage the participants in maintaining your driving performance program, right? That could happen again and again, but that would address how do you keep your cognition engaged? How do you keep your physical skills up? What do you do for your vision? What doing a car fit event as part of that, like, and then measuring the success rate with that. That's all. I still want that to happen.
Yes. Project Search is the high school version of Country Roads. So it's high school students who are bused to WVU Medicine Ruby Hospital, and they are given job coaches there, and they're taught on the job skills. They circulate between different departments in the hospital. And if they complete the program, they're offered a job there, which is phenomenal, except some of them aren't from here and they need to pivot to independent living situations at the time of high school graduation, some of which are ready to do that and some of which are not. And they're here for a year. So they're engaged for the whole school year. For the vast majority of their day, they're bused here in the morning, they're bused home in the afternoon, wherever they're from. And again, great OT opportunities. Accessibility Services is the department here on campus that supports people with learning or testing accommodations. So,
And physical.
yes, and physical
Technically.
disabilities. Yes, thank you. From a perspective of students who have learning accommodations or testing accommodations, they provide a very narrow amount of services that don't always have the actual skills the student needs to be successful. They don't teach them and then follow up with their ability to actually implement those programs. I think Jacob probably has some experience with that with a particular client he's working with right now. And the OT perspective of working with people and providing structure and habits and routines to make them successful in their college experience.
Just giving them extra time for testing doesn't help them with homework, doesn't help them with being an effective studier, that kind of stuff. And that's the stuff that OT could really work with. Again, would be so cool.
And the last place that I've identified, just kind of, paying attention for the last few months and just kind of getting my wheels spinning is I went to a speaker who was from Extension Services, which we kind of, probably know as 4-H. And I went to her presentation. She was talking about all the wonderful, wonderful programming that 4-H does. And she says, one of our dreams would be to make our 4-H camps accessible for physical impairments. And I'm like, seriously, that's our bread and butter. We can do that, they just don't know who to ask and how to get it done. And one of the questions that we had in the other group was, well, what about funding? Some of these things take money, how do you redesign a 4-H camp? As part of that 1-year lead up process, if it takes funding, the student can identify funding sources, can apply for a grant. WVU has graduate level grants, but also external funding. There are places that want to give people money for doing, projects that revolutionize and change the world. So they would definitely have the opportunity to do grant funding applications.
I think the thing that's really neat that we ended up talking about it more last time is that the student starts the planning process. They take their first class in this process the fall semester of their second year. So they're a year away from starting, more than a year away from starting the capstone. And they take a class where they plan it, and that's where they start to reach out to who it is, where they think they're going to go, and what do you guys need, and starting that needs assessment process and doing the lit review. And then they take a semester off where Sue Ann works on getting all of the administrative stuff and making sure we have contracts and blah, 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 blah in place. And then the summer of their third year, their first field work, they come up with their concrete plan and they write their objectives. And if they need an IRB, they do their IRB submission. So, I mean, literally they show up on site ready to go, not like, oh, because I think a lot of times people are worried about, well, how much time am I going to have to spend with them when they show up, getting them up to speed. The goal is they show up at speed And they need like an intro tour, a walk around and meet some people, but then they start their project because they've done all the prep work. So that it isn't meant to be a great, because when you have a level 2 fieldwork student, there's a lot of time spent at the beginning. It's not meant to be that. This is someone who, like she said, this is someone who could be taking their board exam and could be getting a job at your facility.
I wasn't interested.
Except now they're gonna be doing a capstone. And then getting a job at your facility.
Yeah.
So we're very excited to hear your thoughts and your feedback, and especially those of you who've been quiet online.
Throw it up in the chat.
Yeah, we have just about 7 minutes left as we wrap up. So let's kind of hear what you guys think about this. Austin, what do you think? Great. So think about this, Austin. As an MOT graduate, you have the definite capabilities to supervise an OTD capstone student someday. You'll be working somewhere that you will identify some need in your place and you can partner with them. So don't be intimidated by the process. I'm actually kind of happy that you sat through it. It's not a big mystery. It's a pretty cool thing.
And there's no like you don't have to have a year's experience to have a
Yeah,
capstone.
yeah.
Got an idea.
I think it'll be good.
Yeah.
Yeah.
All right. Let's see. My friend Beth is on here. Beth, let's hear from you. I'm gonna call you out. That's what happens when you're a adjunct instructor.
Hi, Sue Ann.
Hold on, Beth. Hold on. I think my volume's down. Just a minute.
Can you hear me yet?
Panel 2 next to you.
All right, Beth, can you say hello?
Hello. I still hear you.
Oh, there she is.
There you are. Can you say hey?
Hey.
Oh, we still can't hear you. Weird.
Try changing, can you change the audio one?
Oh, yeah.
Where do you mean?
I think it's beside the,
Beside the camera.
beside mute.
Where it says, no, on the Zoom screen, the little up arrow by the mute
No,
button.
that's my audio. Oh, select a speaker. Hold on.
I think that's what we had.
Try this.
Yeah.
Say hello.
Hello again.
Okay, now we're ready.
Well, actually, that was already my question about what level you have to be to take these students. So if a master's OT can take it. But I was thinking as you were answering that, the timeline of if my dream, like Diana said, my dream idea, how soon would that have to be formulated? How soon does all this technically take place?
We would have our first students starting the planning experiences coming August.
The planning starts in August. Okay.
But that's just the first cohort. If you don't have a dream yet, then there's good. Ideally, that if we don't screw this up, there'll be cohorts after that one.
So you plan in August for
the next, not for the, they start planning in August to start the next, like a year and a half out, 18 months later.
Right.
Yeah, there's, so it's months of planning.
Okay.
So you got plenty of time to figure it out.
Yeah.
Appreciate
Thank you.
Yeah, thanks for that. Any other questions?
How about Sarah and Taylor? Any dream plans there?
They're like, oh God, you call us.
Turning your camera off does not make you invisible. All right. Well, we appreciate your attention and your time today. And this concludes our CEU track. Oh, Taylor says, I have a fussy baby. Capstone and Encompass Bridgeport. Will you keep us up to date on a specific project or plan? And we will reach out. We love that. And tell that baby we said hello. All right. Have a great afternoon, everyone. Bye.
No, I can't.